Proses pendaftaran PPDS Ortopedi dan Traumatologi Indonesia. Pertama, Anda dapat ketik dan masukkan URL berikut ini pada browser Anda. Setelah masuk, pilih menu berikut dan pilih registrasi. Lengkapi data diri Anda pada halaman pendaftaran yang tersedia dengan lengkap dan benar. Selanjutnya, klik tombol register. Jika data yang dimasukkan sudah sesuai, maka sistem akan menampilkan tampilan berikut ini, yang menandakan registrasi peserta PPDS telah berhasil. Kemudian klik tombol OK. Selanjutnya, pastikan Anda mendapatkan email konfirmasi pendaftaran melalui email, yang berisikan informasi registrasi telah berhasil, dan permintaan untuk melakukan pembayaran biaya registrasi. Jika pembayaran telah dilakukan, proses selanjutnya, upload bukti pembayaran pada sistem yang telah disediakan. Masuk kembali ke website, klik menu berikut, dan pilih registrasi. Setelah terbuka halaman registrasi, kemudian klik sign in yang ada di sisi kanan halaman. Masukkan email dan password yang telah dibuat saat proses mendaftar sebelumnya. Kemudian klik sign in. Setelah berhasil masuk, selanjutnya klik menu unggah berkas. Unggah bukti pembayaran biaya administrasi ke sistem. Klik tombol submit. Dan klik tombol OK, yang menandakan upload bukti pembayaran telah berhasil. Proses selanjutnya adalah verifikasi. Data yang telah diinput dan dokumen yang sudah diunggah ke sistem oleh calon PPDS, selanjutnya akan diverifikasi oleh admin kolegium. Setelah terverifikasi, calon PPDS akan dikirimkan email notifikasi, yang menginformasikan sudah dapat melakukan cetak profil. Untuk mencetak profil, calon PPDS masuk ke halaman ini kembali, dan sign in. Kemudian klik cetak profil. Kemudian profil yang telah dicetak digunakan untuk melanjutkan proses seleksi pada prodi ortopedi dan traumatologi yang dituju. Setelah seluruh proses selesai, dan telah dinyatakan lulus, Anda akan menerima email notifikasi kelulusan. Dan status pada sistem akan berubah menjadi PPDS aktif. Selanjutnya Anda resmi menjadi anggota muda PABOY. Dan dapat melakukan sign-in sebagai anggota muda PABOY. Masukkan URL berikut ini. Setelah masuk, klik tombol login yang berada di pojok kanan atas. Masukkan alamat email, password, dan pilih login sebagai PPDS. Setelah berhasil masuk, anggota muda PABOY dapat melihat status keanggotaan PPDS aktif, dan juga informasi data diri dengan lengkap. Demikian video tutorial series kali ini, dan jika membutuhkan bantuan, Anda dapat menghubungi kami di sini.
Mari kita tingkatkan level masker kita Surgical mask bisa didouble dengan menggunakan masker kain seperti ini. Semoga aman selalu, salam sehat.
Good afternoon, everyone, and welcome to the first Asian Orthopedic Association webinar series. And I hope all the participants are having an excellent afternoon wherever you are. And I've been looking at the messages in the host and panelist chat. I've seen Professor Lee, Professor Pasyong, and Professor Tira Chai. Thank you for the excitement that you all bring to this event. And I want to say welcome to the first of the AOA webinar series. And the Indonesian Orthopedic Association got the honor to host this first of many series to come. And this event is also supported by the subspecialty organization in Indonesia, which is the Indonesian Orthopedic Trauma Society. And the theme that we are having this afternoon is advanced orthopedic trauma, and we're going to have lots of case discussions. So that is what's in front of us, exciting cases and discussions ahead of us. So if the host can show the schedule of the day, please put it on the screen. And the committee has just informed me that we have already had 1,000 registered participants, not including the ones that are joining us from the YouTube live session. And the participants that joined these events are from Brunei Darussalam, Indonesia, Malaysia, Philippines, Singapore, and Thailand. So Again, this is a very exciting event, and I hope you all are having an excellent afternoon. And before we begin, I would like to read some of the rules and regulations of this webinar. So if the host can show the rules and regulation, please. All the materials will be presented in English, both by the speakers, and also if there are any questions from the participants, it will also be asked in English. And please, for participants, we would like to ask for the voice and video from the attendees to be deactivated. And we inquire questions by typing in the question and answer feature. And also, you are allowed to use the raise hand feature for direct questions. And this will be guided by the moderator. And then all attendees are requested to follow the webinar until the end of the session. An e-certificate will be sent via email to every participant. And for your information, this webinar is also available in YouTube streaming by clicking the link bit.ly/AOA webinar series. Please take note of the capital letters because it's case sensitive. Okay, I do not want to make you wait furthermore. So without wasting your time, we are going to hear the opening remarks from the chairman of Indonesian Orthopedic Trauma Society, Dr. Bambang Gunawan. The time is yours.
Thank you very much, Dr. Yefta. Can you hear my voice clearly?
I can hear you loud and clear, Dr. Bambang.
Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. First of all, I would like to thanks to God that we still in good shape and still healthy and still possible to meet in this situation that we are still in pandemic, but thanks God also that we still survive and still have good, healthy, and we can continue our activity day by day. And now it's look like that the condition is become better. And also thanks to all of the distinguished guests, and also to the participants, and also to the committees that make this situation happen. And I hope that we can share our experiences and we can share our knowledge, and also hope also we have the benefits of this meeting. And I think we are in the Asian countries, we facing many same problems, many same conditions, and also we have many things that similar. Yeah, we have the similarity, and I hope this meeting can continues, yeah, in the future, and will hold by will help by your country, and also makes the knowledge and also the experience become better and better, yeah, in the future. And I think all of the effort that made by the committees, yeah, to make this meetings happen, yeah, so I appreciate it. And also all of the participants that I heard it came from almost all of the ASEAN countries. Yeah, so also for the residents, yeah, we hope all of the residents in all of our countries can have the benefit of this meeting. Okay, I think that's I want to say to you all. Hope that you can enjoy this meeting, and we hope also we can continue this kind of meeting in the future. Okay, thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Bambang, for the kind
Welcome.
opening remarks. And then I would like to welcome Dr. Edi Mustamsir as the president of Indonesian Orthopedic Association to give one or two opening remarks. Please, Dr. Edi.
Thank you, Dr. Jefta. Can you hear my voice?
Loud and clear, doctor.
Yeah, okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. First of all, I'd like to thank all the council members of Asian Orthopedic Associations, the General Secretary of AOA, Prof. Fashong, and Prof. Liang Hin as the Educational Committee of AOA, and also Prof. Danieli for coordinating these webinars. All the faculties from Indonesia, especially from IOF, Indonesian Orthopedic Trauma Society, and also from Malaysia, Thailand, and also the local organizing committee led by Dr. Andika Yudhistira, who have worked very hard for making this first webinar series can be conducted today. It's really a great honor for us Indonesian Orthopedic Associations to be elected as the first host for this webinar series. Actually, the idea of having the educational activity in regular basis for AOA community during this pandemic started in chats in WhatsApp groups proposed by Prof. Chi from Malaysia a few months back, and it is supported by all the council members, and now we are here for these webinars. I believe we have many unique cases in this region of the world and that may not be available in other parts of the world, and we have so many experts that will be more than happy to share their experience to all of us. And in today's webinars, the topics will be very interesting, pelvic and acetabular trauma. And we will have chances to discuss these difficult types of fractures with experts in this field. We are also very happy to see that a lot of participants have registered for this webinar, and hopefully we all can learn something and keep the spirit of Asians among us, the Asian orthopedic community. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Edi. What a warm welcome. And I do believe that what Dr. Edi said is also very true, that we have special similar cases in Southeast Asian that cannot be found anywhere else in the world. So hopefully this will be a special learning experience for all orthopedic staff, even residents. And then up next is the pre-recorded opening remarks from the president of Asian Orthopedic Association, Dr. Che Ping Ching. Unfortunately, she couldn't be live here this afternoon because of another important meeting that she needs to attend. So if I may, the committee will play the pre-recorded opening remarks from Dr. Che.
A very good afternoon, my dear orthopedic colleagues in ASEAN. Welcome to the first AOA educational webinar. First and foremost, I would like to thank the council members of AOA for their unwavering support and Professor Lee Eng Hin for taking the lead in organization of this webinar. When COVID-19 forced us to stop our physical meetings and conferences, we discovered Zoom, Google Meets, Teams, which allow us to reach out, learn, and share, and do so much more online, irregardless of our distance. It is under such circumstances that I thought, why not we gather our best teachers in ASEAN and organize some teaching webinars to benefit mostly our junior colleagues. Thank you, Professor Edi Mustamsir, IOA President, Professor Bambang Gunawan, IOTS Chairman, and Dr. Andika for making this first webinar possible. Thank you too to all the country representatives who will take turns to organize the subsequent webinars. We have so much hidden talents and expertise and good teachers in ASEAN. Let us take this opportunity to reach out and to learn and teach as much as we can in the true spirit of ASEAN. I wish you all the best, and please take good care of yourself in this pandemic. Thank you so much.
What a wonderful message from Dr. Chie as president of the Asian Orthopedic Association, which I agree that even amidst of this pandemic, we discovered that online meetings can be very effective. And I can see so many great names in the schedule for this afternoon that makes me feel as if I'm standing in the shoulders of the giants. And last but not least, we will have an opening remarks, and also this event will be officially opened by the General Secretary of the Asian Orthopedic Association, Prof. Passion. Please, Prof. Passion.
Thank you, Dr. Japta. Can you hear me?
I can hear you loud and clear, Professor.
Thank you. Good afternoon to everyone. On behalf of the ASEAN Orthopedic Association, I would like to welcome all of you to this first virtual AOA webinar for 2021, entitled Advanced Orthopedic Trauma Case Discussion. This is hosted by the Indonesian Orthopedic Association, headed by Dr. President Eddie Mustamsir, with the able support of IOTS Chair Dr. Bambang Gunawan.
Excuse me, Professor Passion, you are muted, sorry.
Sorry. Last July 10, in a virtual online meeting, the AOA Education Committee, chaired by Professor Lian Hing, formed an ad hoc committee on webinars to prepare the AOA education program schedule this year. Its national association was represented by a country representative. Ably assisting him is the co-chair, Professor Denny Lai. The webinars committee agreed to hold AOA webinars every 2 months to be hosted by a national association. The different webinar topics will focus on the different specialties of orthopedics. Today is the first host is the Indonesian Orthopedic Association, and the topic they chose is on trauma. Congratulations to Professor Denilai and Dr. Andhika Yudhistira for their unselfish and untiring efforts and dedication in the preparation of this webinar. I would like to thank the distinguished faculty speakers who have accepted the invitation to share their expertise and experiences in this field of trauma. They are namely Professor Tirachai of the ARCOST, Dr. Datuk Abdul Rauf bin Ahmad, Dr. Gibran Kristan Alfarian, Professor Ismail HD, Dr. Radi Mulyana, Dr. Harisuko Wihandrono, and of course, the moderator for today's webinar, Dr. Imamul Aziz Albar. Here is wishing everyone a good day, and I hope that you will enjoy this interesting and highly informative webinar. Welcome to all. Thank you and mabuhay.
Thank you very much, Professor Pasyong, and I would like to thank you on behalf of the Indonesian Orthopedic Association for continuing to overview our continuing orthopedic education over Southeast Asian nations. Without further ado, we are going to enter the first session of this afternoon, and I would like to introduce our moderator for this afternoon, which is a dearly beloved senior of mine, one of the kindest and humblest person I know. And he is now sitting as the emergency medical manager in Cipto Mangunkusumo Hospital, which is our nation's top referral hospital for trauma cases. So without further ado, I would like to welcome Dr. Imamul Aziz Albar as the moderator for this afternoon.
Okay. Thank you, Dr. Jepta. Did my voice clear and loud?
Yep.
Yep. Okay, thank you. Good afternoon, all participants. Thank you for joining us in today's afternoon session. I would like to thank the committee for giving me the opportunity to host this session, and the session about advanced orthopedic trauma. Today, we hear some talks about and discuss about the orthopedic trauma from the expert. And there will be, like Dr. Jepta said, Dr. Radi, Dr. Prof. Ismail, Dr. Gibran, and Dr. Hari Suko from Indonesia. And we have international speaker are Prof. Terachai from Thailand and Dr. Datu Abdul Rauf bin Ahmad from Malaysia. And question about today's talk can be typed here in Q&A box, and don't be hesitate to ask our speakers. And we will ask the speaker to answer your question after hearing all the talks in the session. Without further delay, I will invite our first speaker, Dr. Radi. Dr. Radi will deliver for the first talk in this session. We hope enjoy today's meal, and the speaker is Dr. Radi. Is a senior orthopedic trauma consultant in the emergency department, Cipto Mangunkusumo Hospital. Dr. Radi, the time and screens are yours. Please, Dr. Radi.
Thank you, Dr. Imamul. Assalamualaikum warahmatullahi wabarakatuh. A very good afternoon to everyone, especially to professors, seniors, and all colleagues, and also all the participants that are here in this webinar. This is a big honor for me to present one of the topics. My topics will be about timing of fixation in polytrauma and pelvic acetabular fractures. So I would like to start with the contents. In this next 10 minutes, we will have a case illustration, and then we will reinforce the definition and algorithm for polytrauma patients. And we are going to talk about the timing for pelvic acetabular fracture definitive fixation in polytrauma. So I would like to start first with the case that's presented in our hospital. These cases of polytrauma is not really an everyday cases. In a year, we only have around 20 to 30 polytrauma patients, but for the major injuries, except the polytrauma patient, we have a bit more, around 200 to 300 cases per year. So this case is a male, 34 years old, with a motor vehicle accident 17 hours prior. Because we are a referral hospital, the patient is referred from the other center or the other local hospital with information of chest, abdomen, and pelvic injury. At the presentation in the hospital, the patient is still alert with heart rate of 76, although this is a bit misleading because the heart rate is actually not strong enough. The pulse is not strong. And the pulse pressure is 78, the blood pressure is 78/56, and the saturation is 99% with temperature of 36.5. We perform the resuscitation for the patient. We apply the pelvic binder and then administer fluids and then continue with packed red blood cells and then fresh frozen plasma. Our lab results showed that the hemoglobin is 8.7 with lactate 257,000. With lactate is around 4. So we are not really, we still have to evaluate about the resuscitation. And after resuscitation, we can maintain the systolic blood pressure at around 100 to 110 with heart rate between 95 to 100 per minute. And we assess the patient after we do some x-rays and lab results. This is a polytrauma patient, score 32 if we use the ISS, the ISS. And if the cases are the pelvic acetabular fractures, consists of symphysis disruption, this one, left SI joint disruption, and then left superior inferior pubic fracture, and then anterior column fracture. The acetabulum is also involved. And also the patient have partial urethral anterior rupture, which is common in this symphysial disruption, and also closed fracture of the rib. I don't have the picture here. and also blunt abdominal trauma with the suspected is the hollow viscous, and later we know that it's a sigmoid colon and also the liver hematome. And using the Hanover algorithm, it's a borderline polytrauma. So we plan for the patient to do the damage control surgery and damage control orthopedics operation. And afterwards, we perform the anterior frame application. The urethral tamponade is performed by a urology division, and the rib fracture is treated conservatively, and there's a laparotomy and sigmoid colon resection with colostomy from the digestive division. And this is a multi-discipline approach, and then we have 6 days of admission for the ICU, and then the patient is planned for stage definitive fixation. And this is the definitive fixation afterwards. The definitive fixation is that we change from the anterior frame into the internal fixation. As you can see, we put the plates to maintain the symphysial disruption and also the sacroiliac joint disruption. But you can see that we don't fix past the acetabulum, the anterior column of the acetabulum. There's a reason to this. The reason is because we do this procedure after 6 weeks. So this is one of the challenges faced in our center. So from this case illustration, before I continue, may we proceed with the polling first? To the committee, you might want to help me with the polling, please. So I would like to ask to all the participants, according to your knowledge and your experience, what is the optimal time to definitive fixation for pelvic acetabular fractures in polytrauma? You can answer in the next 30 seconds, I think. We have the immediate or under 24 hours, and then 1 to 5 days, 5 to 10 days, more than 10 days, and we make it relative. Okay, so most of you answer it that the optimal time for definitive fixation is around 5 to 10 days. Only 6% feel that it will be possible to do it less than 24 hours, and also only 7% tell me that there's a relative time or no set time. So, okay, we can continue with the discussion. Okay, I will remind us all about the current polytrauma definition that we are all agree on. The polytrauma, according to the Berlin Consensus in 2014, are that if the patient have injury in more than 2 regions, at least 2 regions, sorry, with each region AIS score at least more than 3 or more. So the AIS score is the score that we have to know. I could not explain it thoroughly here, but we can read it later. And plus, we have to include at least one of these physiologic parameters, whether it's hypertension, unconsciousness, acidosis, coagulopathy, and age more than 70. Our patient that I presented before have 2 regions, pelvic, or it's included in the extremities, and then the abdomen and also the thorax. They have 3 regions, sorry. And the pelvic is score 4, and the abdomen is also scored 4 or 5, sorry, and the thorax is scored 2. So we have completed the area, the AIS category, and then we have hypertension during presentation. So my presented case is one of the polytrauma, and then we remember about the algorithm that I put here. It is modified from the AOA principle of fracture management. The most that we know about polytrauma patient is that this right side, we do the stage operation. So we do the damage control or early total care if it's stable. But usually, if the acetabular or pelvic acetabular fracture, usually the patient is at least a borderline patient. So we usually use the damage control orthopedics, and then we use the stage approach or the second operation before we do the definitive fixation. But I would have to remind us all that there is an evolution of the timing of fracture fixation in general, not only the pelvic acetabulum, from the early total care, and then there's the damage control of orthopedics during the early 2000s. So all of the patient is performed damage control orthopedics, but after that, there are many papers published that is not always strict to perform the DCO. We have to see whether we can stabilize the major fractures and then see the elected levels as in EAC, early appropriate care. And then there's also the safe definitive surgery that is trying to avoid the overuse of the external fixation. And then the last one is the PRISM. It's also trying to individualize the management, not only the physical condition, but also reflecting on the local resources. And this is one of the recent papers that it said that the trends in the definitive fixation of the pelvic acetabular fracture with polytrauma is steadily decreasing in the pelvic ring fractures, this one, the red one, because there is improvements in minimal invasive approaches. But in the acetabular fractures, because of the usual severe presentation of the patient, it's still stable in around 5 to 10 days, at 5 days plus. Okay. But according, if we come back a bit to this PRISM individualist safe management approach, there are no really time limits for surgery. What I would like to tell you again is that if the patient is able to be stabilized, if we can see that the physiologic parameters is improving, and we don't have any other reason to not do the definitive operation during the first, second, or third day, or maybe before 5 days, then we can do the definitive fixation. So my answer would be there will be no definitive days for definitive fixation in pelvic acetabular fracture in polytrauma. But we have to remember is how long is too long for this fixation. There are several papers published before that if we pass the 15 days of the for the elementary fractures and 5 days for the associated fractures, usually we have difficulties in performing anatomical reduction. And the outcome will also be decreased if we perform the fixation in more than 15 days for the elementary and 10 days for the associated type fractures. And also the more recent publication said that it's better in anatomic reduction in less than 14 days if compared to the more than 14 days. So as a summary, because the time is up, a stage surgical approach is still preferable as opposed to directly stabilize all the fractures, because we also face with another type of injuries, not just the orthopedic injuries. And also the pelvic acetabular fractures are stabilized as early as possible based on the individual patient physiology. So if the physiologic parameter is all better, then we can proceed without a fixed window of opportunity. We know that the early 2000s AO fracture, the reference from AO said that there is a window of opportunity between the day 5 to day 10, but it's not a fixed window. It's according to the physiologic parameter of the patient. But the delay of more than 14 days may reduce the chance for optimal reduction and outcome. Thank you for the chance to present here. Assalamualaikum warahmatullahi wabarakatuh.
Salam. What a great presentation delivered from Dr. Radi. And maybe for the question we hold first until the session, all the presentation was done. Okay, the second speaker, I invite Professor Ismail from Prof. Ismail is my teacher, okay, from orthopedic from University of Indonesia, Cipto Mangunkusumo Hospital. And Professor Ismail will deliver topics about diagnosis, what to look for in the radiograph and CT scan. To Professor Ismail, the time and screens are yours. Please,
Okay.
Professor.
Thank you, Dr. Rimamul Aziz. I like to share the screen first. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. My job is present about what to look in the radiograph and CT scan. Before we start the presentation, I would like to have the polling survey about how many operative cases of the acetabular fractures have you done or involved so far. This selects in next 15 seconds. Either 1 and 10, 11, 20, 21, 40, and above 50. Yes, please. Okay. So we have mostly is 10, about 10 cases, less than 10 cases, 59%, and 1% is above 50. Okay, thank you. Okay, it's not work. So the problem in the acetabular fractures is displaced intra-articular fractures in the weight-bearing joint. So the anatomy is the acetabular is hemipelvic, analogous to the inverted Y, supporting the acetabulum. This acetabulum consists of two columns. That's why that are anterior column and posterior columns. And the pictures. The white is represent anterior columns, and the red is the posterior columns. And this is the anatomy. The anterior column consists of the pelvic brim, anterior wall, superior pubic rami, anterior border of the iliac wing, and the posterior column consists of the greater and lesser sciatic notch, posterior wall, ischial tuberosity, and most of the quadrilateral surface. And the dome is to reflect the main weight-bearing area of the hip joint, correspond to the roof arc measurement of 45 degrees on plane X-ray and circle 10 mm inferior from the vertex of the acetabulum on CT. Roof arcs measurement on 3 view on AP considered to be unstable if less than 45 degree. In the obturator oblique is less than 25 degree, and iliac oblique less than 70 degree. This is the case, male 30 years old, with because of the motorcycle accident in this case. So you can check clearly. So how about the diagnosis? The diagnosis in this case is the closed fracture dislocation of the left hip. Consists of the posterior dislocation of the left hip and closed fractures of the left acetabulum. But how about the classification? Do you need additional imaging in this case, beside of the AP view? So we order alar obturator, inlet outlet, and CT scan 2D and 3D. This is the pictures of the inlet, outlet, alar, or iliac oblique, and obturator view or Jude view. Plain radiography is the basis for the most treatment decision. The standard epi, what you have to look for in the AP X-ray. The first one is the iliopectinal line that represent of the anterior columns. And the second is ilioischial line, represent of the posterior columns. And number 3 is dome. And then anterior wall, posterior wall, and teardrops. And this the evaluation. Again, ilioischial line, posterior wall, anterior wall, domes, teardrops, and simulate in the shin bone to make you more clearer. This one, anterior wall, posterior wall, and anterior wall, and for the spatial X-ray like obturator obliques, this one 45-degree tilted, yeah, on the affected side is tilted. So this usually evaluate the anterior column and posterior wall, but completely in obturator oblique you can find the pelvic brims, and then number 2 is posterior wall, number 3 is mid anterior column, and spur sign. Spur sign is clearly view in the obturator obliques and obturator foramen. And for the iliac obliques or alar view is evaluate posterior column and anterior wall. So contrary, posterior column and the wall is anterior. In iliac oblique, you can evaluate the sciatic notch, anterior wall, posterior column, iliac crest, and posterior wall. And this is the sequence from pictures of the epi, obturator, and iliac obliques. We can see this one again, epi view, obturator, and iliac oblique or alar view. We can check that obturator sign, yeah, in the red dot, this red arrow. This is the spur sign. Spur sign. What is the spur sign? Spur sign is the triangular fragment of the iliac bone that remain attached to the sacroiliac joint, but is it separated from the fracture acetabulum. This indicated of the both column fracture, ABC type. So if there is spur sign, so you can jump directly, you can classify this one is ABC types. And how about the next imaging? CT scan, 2D, 3D, and other modalities. In 2D, you can see posterior ring fractures, and then femoral head and loose body. You can detect in 2D, and marginal impaction. Marginal impaction is very important in 2D, and the size, aerotension wall and column, and unrecognized T components. The marginal impaction is first introduced by Jude and Latournelle. This one is affected articular fragment and subchondral bone are rotated and impacted to the underlying cancellous bone along the fracture margin. And how about the 3D? The 3D is useful for the lead reconstruction and educational aid, and the most important also in transitional pattern. Like in this case, this one is we cannot show about this one a variant about in between ABC type or T types with the quadral surface combination. So in 3D we can detect. Actually, there is spur sign, but is undetected because of undisplaced spurs, undisplaced of spur sign. And another imaging is we can do evaluation of the lower genitourinary tracts if there is anterior ring injury or acetabular fractures low anterior column. And how about the classification? How to classify and why? Yeah, because you cannot discuss Shakespeare's if you do not know the English language. You cannot discuss fracture pattern if you do not know classification. It's very good. If you cannot classify the fractures, you don't understand it. if you don't understand the fractures, you probably cannot reduce it. And if you cannot classify the acetabular fractures, do not do the acetabular surgery. This is the classification, this very classically, judeolaternal. There are 10 types, 5 simple and 5 associated types. So how to classify it? We need the number 1 is primary line. We need iliopectineal line that represent of the anterior column and ilioischial line that represent of the posterior column, and secondary features, posterior wall, inferior pubic rami, obturator ring, and spur sign. So this algorithm, how many column involved? So no, so it must be posterior wall fractures. If the column involved, that's once again, iliopectineal line is represent anterior column, and ilioischial line is the posterior column. So 1, so it must be, if IP must be anterior column or anterior wall, and if the ilioischial line must be posterior column or posterior column, posterior wall. So we screen with the, is there any ischial ramus fractures in the obturator oblique? No, so it must be anterior wall. If yes, there are 3 possibility, and we screen again, is there a wall component, posterior wall component in the obturator obliques? So if yes, so it means that will be the we classify as the posterior column, posterior wall. And in the 2 column, there are 5 possibility: transverse posterior wall, T-shape, ABC, or anterior column posterior hemi transverse. We screen again with the ischial ramus fractures. No, it must be transverse or transverse posterior wall. And how about differentiating in these 2 classification? So if there is posterior wall component, it will be transverse posterior wall. And so for the, if there is no, if there is ischial ramus fractures, there are 3 possibility: T-shape, ABC, or anterior column posterior hemi transverse. We screen again with is there any iliac wing fractures? Yes, ABC and anterior column. And no, so it must be T-shape. So if there is spur sign, yeah, in between 2 this ABC and anterior column posterior hemi transverse, if there is spur sign positive, so it must be associated with column. So this we go back again to the first case that I show you previously. So this is the pictures in 2D, and this one in 3D CT scan. So in this case, there are 2 columns involved, yeah, and then there is ischial ramus fractures. So in this case, it means if there is ischial ramus fracture, there is no ischial ramus fractures. So there will be 2 possibility: transverse of transverse posterior wall, and because there is a posterior wall component, we can check on the red arrow. So this case is transverse posterior wall. So in this case, because this transverse posterior wall, there is component of the posterior wall component. So we do it from the backs, posterior column plate, and integrate anterior column screw. This is the pictures of the alar view and obturator view. And case number 2 is also fell down from the 5-meter hedge. This one. This is the pictures: epi, inlet, outlet. On the right is obturator, so must be in the left is the alar view or iliac oblique, and the other side is left in the iliac alar view, and the right is obturator. And this one, the CT scan. The CT scan. See, again we do the, how many column involved? 2 column, yes, or 1. This one is the iliopectineal line, yeah, iliopectineal line. Only 1 column. Iliopectineal line is disrupted. So there are 2 choice: anterior column or anterior wall. So we screen with the ischial ramus fractures. Yes, there is ischial ramus fractures. Yeah. So This one is anterior column. So in this case, we do it with retrograde anterior column screw percutaneously. And case number 3, yeah, this one, how many column involved? Iliopectineal and as well as ilioischial is disrupted. So there are 5 possibility. So is there any ischial ramus fractures? Yes. So must be 3 possibility: T-shape, ABC, or anterior column posterior and transverse. So does the fracture involve the iliac wing? Yes. There is no iliac wing fracture, so it must be T-type fractures. So in this case, with from the back, doing the posterior column with the anterior column screw, yeah.
Sorry, Professor Mail.
Yeah,
3
take
more
message.
minutes.
Yeah, this one, knowledge of the plane radiology is essential since it is the basis for the most treatment decision. Other modality are adjunctive. Classification of the acetabular fracture could decide to manage physician of the acetabular, whether you do it by anteriorly or posteriorly or combined, yeah, or in one approach. And the decision of the classification is based on the primary line, iliopectineal line, and ilioischial line. The secondary features like posterior wall, inferior pubic rami, obturator ring, spur sign are helped to classify the acetabular fractures. And in the 3D, you can evaluate the posterior ring, femoral head, loose bodies, marginal impaction, size and orientation wall column, and unrecognized T components. And 3D recon, you can evaluate the late reconstruction for the transitional pattern purpose or educational aid purpose. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. What so informative presentation from Prof. Ismail. Maybe we hold for the question and we continue to the next presentation. So Professor Terachai will be bring about the setting up for success, choosing your approach. Professor Terachai is the senior staff in the trauma, in the orthopedic trauma in the Chiang Mai University. You have 15 minutes, Professor Terachai, for the presentation. Time and screens are yours, Professor. Please.
Can you see my screen now?
Yeah, very clear, Professor.
Okay. Good afternoon, everyone. It's my honors again to share my experience with the colleagues in Asian country about the acetabular fractures. I think this is not an easy one, but as we said, okay, we have to do something to treat our patient in different to the another region. My topic is setting for the success, choosing your approach, how to approach the patient with these acetabular fractures. Just a moment. Okay. I will talk about, does the fractures require operative treatment with ones, when to operate, and which surgical approach, and what is the sequence, and what is your competency, how to prepare yourself, and how prepare your team. I'm sorry, there's some delay in the changing.
Yeah, never mind, Prof.
The slide doesn't move. Just a moment.
You can stop share and reset. Bro.
Yeah, okay. I hope it worked. If it not, I will reset sharing again. So Professor Ismail already mentions what is the classification of these acetabular fractures. You have to know all this classification, but it's not easy. More or less, yeah, you have to think about the simple one, yeah, the elementary fractures, and the combined time. This is more difficult one. Yeah, as Ismail mentioned, if you cannot classify the fractures, that means you don't understand, and you may not able to approach and reduce the fractures. Ask yourself, does the fracture require operative treatment? Which one? Yeah. What is the factors? The patient factors, fracture, surgeons, and facilities. I emphasize on the surgeons and the facility of this treatment, because if you don't know the fractures, it's difficult, as many of the faculty show you. And also the instruments. If you don't have the clamp, you cannot reduce the fractures. It is not like a long bone that you can use your fingers or the resident to reduce. But this one, you need the really, very strong clamp to close the fracture gap. Yeah, Ismail already mentioned how to evaluate the fractures in the AP and 2D view and 2D and 3D. I think for the young resident or the young doctors, you have to understand the plain X-ray first. And then you look at the 2D CT. Don't just jump it to the 3D CT and then you didn't learn anything. You have to look at the 2D, and then the last one is the 3D, that, yeah, you like training your brain, yeah, to differentiate the fracture line. 3D cannot show the articular impaction, so you have to use all the view to see the fractures. Degree of the displacement, if you have more than 2 millimeters, yeah, is very poorly tolerated. Yeah, and there's the problem of the osteoarthritis in the futures. So most of the acetabular fracture will require operative treatment, except the non-displaced, or even some non-displaced. Now we can do the percutaneous to fix it without reduction. What is the non-operative indication? It's uncommon now. That means you have the congruence in all three views without traction. And the fracture displacement is less than 2 millimeters. And the joint is congruent. That means you just have the like a non-displaced fracture line, yeah, and you want to make a bed rest for a while. Yeah. Normally, you just make a bed rest with or without traction. And if there is non-displaced from the beginning, yeah, sometimes early mobilization is the option. There are, for me, only one fracture that may be indication of non-operative treatment. I call this the secondary congruence in the acetabular, both associated both column fractures. That means you have the fractures above the acetabulum dome. Yeah, like in the both column, as Ismail show you the spur sign. Then the fracture is moving, like in this medially shift of the medial wall. You see many fracture lines, yeah, but clearly the joint is not that bad here. Yeah, maybe if the patient are not allowed, the condition is not allow you to do the operative treatment, it should be okay to treat with this. This is a CT scan, and this is 1 year. The fractures heal with the congruence of the joint, but some problems maybe, yeah, if you have the massive shortening. So the surgical indication is clear that if the joint is not congruent, displacement more than 2 millimeters, posterior instabilities, you have a joint subluxation or retained intra-articular fragments. When to operate? Acetabular fracture is not an emergency surgery. Yeah. we have to resuscitate the patient like in the first lectures. But however, delay surgery more than 2 or 3 weeks, that's affect the ability to reduction and to obtain the good outcome. I think for elementary fractures, 15 days acceptable, but in associated fractures, 10 days, not more than 14 days, that should be another good time for surgery. Ask yourself, have you operated these fractures? How many cases? When was the last time you operated? Are you sure that you can make the patient better without no infection? Somebody show you the x-ray without reduction of the fractures, there is the implant in there. So this is not an easy one. I think you start first. Yeah, the most easy one is the posterior wall, and then posterior column, posterior wall, and then transverse. Yeah, and you learn from the simple one to the difficult one. Somebody may say in the past when I trained, they said, okay, you have to operate more than 50 cases and then you will get a good result. Yeah, but now with the teaching, yeah, and many of the courses, maybe we reduce to the 30 cases. Okay, this is all the thing you have to prepare. Reduction clamps, as I mentioned, yeah, you need this one joystick, it's important. And this one is the collinear reduction clamp. That is very helpful. Yeah, from the past, we cannot reduce the posterior column from the anterior. With this instrument, we can use it. And we can do only single approach to reduce the posterior from the anterior approach. I think it's available everywhere now. The price may be not so expensive compared to in the past. Lateral table, Jackson table, this is the best option, yeah, to see all the oblique view in the acetabular area. However, I'm not sure how many of you have this Jackson table. If you don't have it, yeah, you can make yourself. Yeah, use a wood here and apply some of the supporting. Yeah, and all this is lateral, but it is the wooden board. Prepare your team. Talk with your anesthetist. If you have this cell saver, it should be really good. Now, the question is, what approach? Analyze the X-ray. Analyze the fractures. Be familiar with our approach. And you have to know what you can see from each approach. It's like the anatomy. And you know the limitation of each approach. Yeah, I will show some of the approach that is from the anterior. This is the classic approach, ilioinguinal approach. Modified stopper. Yeah, you can see from the medial para-rectus approach. Or you can use the combine the lateral window with the para-rectus or with the modified stopper approach. Yeah, for the posterior, yes, you have the Koger-Langenbeck. This is the classic approach. If you have a superior wall or superior dome fractures, yeah, you need a trochanteric fifth. Extensile approach, I think now is just the mention. Extended iliofemoral triradiate. I think this is the history of the treatment. Now we have more approach to encounter with this, or treat this type of fractures. Or you can use combined anterior and posterior approach. Koger-Langenbeck. Yeah, this is the posterior approach. You can treat all these type of fractures. Posterior wall, posterior column, posterior wall and posterior column. For the transverse, you can go both from front or back, but from the back you can see, but you cannot see it on the front. You have to palpate by your fingers to the front. Yeah, and this is transverse posterior wall, and this is the T-type fractures. You can go from the back, but from the front here, it's difficult to see. You have to palpate it. Yeah. Trochanteric flip. If you have the superior acetabular fractures here, yeah, from the Cocker-Langenbeck, you cannot see. You can see it, but you can fix this fragment. So you need to flip the trochanters to approach the superior dome here, superior wall. Yeah, this is the trochanteric osteotomy. That this is the access that you can do from this approach. Ilioinguinal approach. This is the classic anterior approach. Yeah, you can use. Now, ilioinguinal is used less in anterior approach because you have some more modified stopper or the pararectus approach. But it's still the classic one. If you have a very long fractures, complicated, ilioinguinal still be the option. Modified stopper. Yeah, this is the funnel steel approach. You can see from inside of the pelvic brim here. Yeah, but you cannot go to the lateral window. Yeah, if you want to go to the ilium, then you have to make another lateral window of the ilioinguinal approach, and then you can join these two approaches to treat these anterior complex fractures. Another one is the pararectus. It's just mentioned about 10 years ago. Yeah, it's very good to access the anterior column and the superior of the dome and some part of this ilium. If you have the fracture in this area, it's very good to have this pararectus. Okay, I show you some case. How many minutes I have now?
3 more minutes, Professor.
3?
3 more minutes, yeah.
Yes, okay. Yeah, if you look here, this is the posterior dislocation of the hip. Yeah, when you reduction, you see the fractures here. This is the superior wall fractures. Yeah, if you look at the CT scan, yeah, this is the superior, it's not the posterior. So the only approach that you can use, yeah, from this CT, you have to do the trochanteric flip approach. Yeah, it's like on the Cocker-Langenbeck on the lateral position. Now you can dislocate the head. You can make a surgical dislocation, and you find this a very big piece of the superior wall. Yeah, we reduce, we fix it. Yeah, and you can see here, this is the superior dome. Yeah, it's the wall, superior wall. This is the posterior. And this is the post-op and 4 months. Another case. Okay. If you look carefully, this is obturator oblique, and you look at this CT scan. Yeah, it's the transverse and posterior wall. Now you have no choice. This is a posterior fractures. Yeah, you can go to the posterior approach, Cocker-Langenbeck. You see the wall and the column fractures. You reduce the column first. Yeah, and then this is the reduce of the column. You make a buttress. Now the next step is to reduce the wall and fix with the screws and the buttress plate again. And this is the final. And post-op with the oblique view. 1 year's good result. Yeah, this is the last case I want to show. This is, if you look carefully, this is the anterior column fractures. There is no fracture here on the iliopectineal and ilioischial line. Yeah. Yeah, for the CT scan, this is the anterior column fractures extend here up to the iliac wing. Yeah, so this is the very intact bone. Yeah, we can use the simple anterior approach of the lateral column supine. Yeah, this is the fracture fragment that you have to bring back to the intact bone of this SI joint. Yeah, you reduce it, maintain it, yeah, to the stable part, and then you put the lag screws. Yeah. From the fragment to the main, and then from the back to the front to the back. You can use the screws. And this is all the screws, 5 screws to treat these complex fractures, anterior column. with only anterior approach. Yeah. This is the post-op X-ray. So take-home message. Decision making in the displaced articular fracture is challenging. You have to understand the fracture classification. Decision to surgeries depend on the patient factors and the fracture factors. Select the proper, if possible, single approach. Yeah. Single approach, you can do the direct approach to the main fragment, reduce it, and fix it to the same approach. Or in some case, it's not possible, you can do the sequence. That means do the main displacement column, like in the T-type fracture with the posterior displaced, then you make a posterior reduction first, and then you go to the front. And don't remember, you need the good equipment to treat these fractures. Thank you very much.
Thank you, Prof. Terachai. It was such an informative and interesting presentation, Prof. So I invite the Dr. Radi and Prof. Ismail and Prof. Terachai to continue to the discussion session. Maybe for the first question comes from Dr. Bagus Yuda Pratama. To Dr. Radi, in your presentation, there is no window opportunity applied in patient with polytrauma, rather using PRISM principle. In DCO principle, it is said that doing surgery after the window of opportunity more than 10 days will carry high risk due to immunosuppression phase. Is it still applicable, Dr. Radi, please?
Thank you, Dr. Imamul, for the opportunity. We are talking about the window of opportunity, right? So what I present in the case is that the window of opportunity that we perceive as a fixed window during our knowledge in the early 2000s is actually not a fixed window, but it can move forward if the patient is stable, and it can even move back if the patient is not stable. Because the concept of window of opportunity is according to the capacity of the patient, the physiologic capacity of the patient. So if the physiologic capacity is good, we can do the second hit earlier. If the capacity is low, then we have to wait until the capacity is better. It's also in the other question, what are the parameters? The basic parameters are we have to avoid the triad of death. So we have to know about the shock or the acidosis parameters. It will vary between center to center, and the coagulation or coagulopathy parameters, it will also vary, because in CHIPTO we only have the PT, APTT, but maybe in the modern center they have ROTEM or something like that. And the third one is the hypothermia parameters. So the basic concept is still used, but it will always improve according to the availability of the diagnostics. Maybe that's the short answer, Dr. Imamul. Thank you.
Okay, so can we say that person is different person to the other person, right? So we look for just the parameter, and we don't have to stick to the rule, right, Dr. Radi?
Yes, it is individualized according to the condition of the patient. Thank you.
Thank you, Dr. Radi. And for the second question, short question to Prof. Ismail, is it recommended to take all AP, LR, obturator, inlet, outlet simultaneously in the emergency setting, Prof. Ismail? Because considering the polytrauma patient comes to the hospital, for example, in the type C hospital, type B hospital with the limited sources, come with the poor hemodynamic parameter. Okay, please, Prof. Ismail.
Yes, thank you. So usually the patient with acetabulum is suspect with the pelvic, pelvic floor, because the acetabulum is hidden in the joint, so we cannot know if there is there any acetabular fracture or not. So usually we do the triad pelvic, like AP, inlet, and outlet view. So whenever we have suspect of if from the AP view or from inlet and outlet is already there is acetabular fractures to have classification. So we order the alar obturator view. That's the first thing, pelvic epi, inlet and outlet. And if there is acetabular fractures, so we order with the alar obturator, and also of course with the CT scan to the entry. That's the I mean the the recommendation. And I would like also have a give comment also to the first question in the polytrauma. So the decision of the definitive fixation is depend to the two decision. The first one is the timing, like mentioned by Dr. Adi, time window opportunity and immunocompromised and reconstruction state, right? According to the timing. And the second is to the objective parameters. So if the objective parameters, there are three option. I mean the three recommendation, like from Junodis, from Waidas, and from Hanover, and etc. Actually, the objective parameter like hemodynamic, lactate level, the oxygen saturation, hemostasis, that one of the objective parameters. So it means although in the first week or in the second week, even in the immunocompromised states, if the objective parameters good, so we can do it the surgery. But of course, the better if the criteria match between timing and also the objective parameters. That's now the trend is like that. So it's not that. So that's why Dr. Radi mentioned put stress on the individualized. Individualized, it means the timing supported by the objective parameters that developed by colleagues from PAPE, WIDAS, or GONODIS. Thank you.
Okay, thank you, Prof. Ismail. And for Professor Terachai, this is a question from Dr. Benedictus from Bali. He asked about, in acetabular fracture with non-operative indication, how long we can start early mobilization after we do bed rest or traction to the patient? Please, Prof. Terachai.
Yeah, thank you. That's a good question. It's depend on the displacement of the fractures. If you have just like a non-displaced, or we call the hairline fractures. Hairline, that means you see the fractured line, but it's not displaced. That means the acetabular cartilage, that is intact. And so there's no, it's like just the pain subside and then you be able to ambulation. But there's the fracture that's minimally displaced. That means it's already break the cartilage. When you make a weight bearing, then you may separate these fractures. So it's different from each other. So that means normally it's 4 to 6 weeks for the traction. For the traction. But nowadays, many surgeons said, okay, 4 to 6 weeks for the young is not easy to do. So they just put the percutaneous screws and then it's done.
Okay. Thank you so much, Prof. Terachai. Maybe I will ask for the three panelists, three presenters here. How about if we found the patient with polytrauma patient with the pelvic fracture, acetabular fractures come to the top referral hospital? Is it possible to us if we do the directly to the CT 3D reconstruction, considering that Professor Terachai said there is the basic is from X-ray, right? So there is two kepentingan there is patient safety and the educational policy. Can you explain about this, Professor Terachai and Prof. Ismail and Dr. Radi, please?
Yeah, I answered it. Maybe the question is, if you have the CT scan, then you may need the brain X-ray or what, like that?
Yep.
Yeah, because I have some problem with my resident. Yeah, they want to complete the X-ray with the 3 view of the AP and 2 days view.
Yep.
And the general surgeon or the trauma surgeon already request for the CT of the pelvis or the abdomen, right? And they said, okay, no, you have to stop because my boss need the 2 days view. That's I said, okay, it's nonsense. Yeah, if you have the CT, then you can skip the plain X-ray. Yeah, because it's more than the plain X-ray. The data you get from there is more. Yeah, so I think in the new ATRS guideline is also written down the same. That's if you have the CT abdomen, the whole abdomen, then you can skip this pelvis X-ray.
Yeah, thank you, Prof. Terachai. How about Prof. Ismail, please? Professor
Yes,
Ismail?
I agree. I still need like mentioned in one of my slides, there is the basis. Yeah, the basis of the management of diagnosis is the X-ray. Yeah, X-ray is very important. Like there's something you miss. Yeah, if you did not do the X-ray, and of course the 2D and 3D CT, there is advantage that I mentioned in my talk, right? And of course, and also another thing is the the response. If you directly do the CT scan, the responding time. It take time, right? And also not every hospital there is CT scan unit in the ER, yeah.
Yep.
Especially in the ER, and this must be also time consuming for the doing the the procedures. Thank you.
Okay, Dr. Adi, last.
Okay, my answer will be if we have an unstable patient, we might not be able to do the CT in the first opportunity. So maybe we can do the more basic examination first, and then do the bedside pelvic X-ray that is more easier to do. And we don't have to move the patient to the CT scan, except if our center have the facility to do the CT in the resuscitation room, then it's a different type. But mostly we have to move the patient and then jeopardizing the safety of the patient. So we go step by step according to the condition of the patient. Thank you.
Okay. Thank you, Dr. Adi, Prof. Ismail, and Prof. Terachai.
Yeah, another option, if
Yeah.
nowadays they use the trauma surgeon, they use the ultrasound. Yeah, ultrasound to evaluate the abdomen and the lower abdomen. Then you can see some part of the injury in the abdomen, and then you may check or request for the. If you have really unstable patient, then sometimes they go directly to the ORA. Yeah, so if there is some blood in the abdomen, yeah, then you have sometimes you just move it and work together with the trauma surgeons to fix the pelvis, just in case you have the unstable pelvic ring in the ORA.
Yeah. Okay. Thank you, Professor Terachai. So clinical judgment is very important for this polytrauma patient. Okay, this is the end of the first session. Professor Terachai, Professor Ismail, and Dr. Radi, thank you very much for joining us in this session. Maybe there will be next session with Prof. Ismail and Prof. Terachai. Okay, we move to the next session. Next session, we will talk. Our speakers are Dr. Datuk Abdul Rauf bin Ahmad, Dr. Gibran Tristan, and Professor Teracai. And for the first presentation will be delivered by Dr. Datuk Abdul Rauf bin Ahmad. Dr. Datuk Abdul Rauf bin Ahmad is a senior orthopedic staff in the Hospital Tuanku Jaafar, if I'm not wrong, in the Negeri Sembilan, Malaysia. And he will bring about the anterior column fractures and the posterior column fractures. Time and screens are yours, Dr. Datuk, please.
Assalamualaikum and thank you, Mr.
Waalaikumsalam
Chairman.
warahmatullahi
Thank you, Mr.
wabarakatuh.
Chairman. I would like to thank the organizing committee from the Indonesian Orthopedic Association for inviting me for this interesting scientific meeting. And I'm glad to give the first topic on the anterior wall or anterior column fractures. This is my hospital. Can you see? Can you listen? Can you hear? Hello?
Yeah, loud and clear, Dr.
Okay,
Datuk.
this is my
Please.
hospital, Seremban in Negeri Sembilan. We have about 1,200 beds and we do all difficult cases including tertiary referrals. Before I proceed, I would like to share my experience. How do I manage the pelvic injury or trauma? First, I establish a diagnosis and then I categorize the injury. Because if you know, pelvic trauma consists of pelvic ring injuries, acetabular fractures, pelvic ring and acetabular combined, and one is spinal pelvic instability. So once you know which category belongs, then you can tackle that category. And then the next step is to determine the instability. And then from there, you determine operative approach and you operate. This has been my practice for so long. And I find it very, very safe and very useful. Okay, how do I establish diagnosis? As mentioned by the previous speakers, we need X-rays, the standard AP, lateral, inlet, outlet views, Judy views, CT scan, all the axial, sagittal views, coronal views. CT scan 3D is very important. And lately, I've been using 3D printing, especially for difficult fractures. For example, complex sacral fractures, where you cannot really see, even from 3D. If you do 3D printing, you can see very nicely. So I would suggest you to start doing 3D printing. How do I make diagnosis? I will use, because based on the categories, I will use tile classification, Young and Burgess classification, Judy Latournelle classification, and for sacrum we use Dennis for simple and Roy Camille for the more complex fractures. So my topic today is anterior wall and anterior column acetabular fractures. Actually, anterior wall is not very common, and even anterior column also not very common. In my practice, most of the cases are all a bad one. I do have a small numbers of cases which I would like to share here. This example where you have anterior wall, you have so-called overlapping articular image, and you have here something you must suspect anterior column. So according to Judy and Latournelle, as you mentioned by previous speakers, these things must be known and must be familiarized before you decide how to establish diagnosis. Okay, for anterior column, anterior wall, you need to see this kind of configuration from 2D as a view. If you see a line like this, anterior wall. If you extend up to here, anterior column. And here, from here, involving posterior wall, if you extend into the further back, it will be posterior column. So these are the example of anterior column. Here you have posterior wall. Here you have anterior column, and here you have anterior wall. Maybe also you have anterior column here. So diagnosis, how about I would like to show you this X-ray. Is this anterior column? From this X-ray, probably you would think this is anterior column, but you must do all this 3D. 3D, I find it very, very useful to confirm my diagnosis. So if you see here, this anterior column, But behind you see a fracture across involving half of the posterior wall. So our diagnosis as anterior column, posterior hemitransverse. And the treatment is different, strategy is different. Okay, my first case, you have a 57 years old female MBA, and this is the X-rays. If you see from the X-rays, looks very benign, congruent joint line, but you see some line here. And then this patient also has a polytrauma, chest injury, rib fracture, and long bone fracture of the humerus. Then upon doing CT scan, then you see this is a fracture. Looks like anterior column on one side, plus the pubic rami, superior, inferior, right side. Also have superior and inferior pubic rami on the left side. And you have also a slight diastasis of side joint with weird fracture of the sacrum. And from posterior, there's no fracture of the posterior wall. So what is your diagnosis based on this? Inlet view is outlet view. So this is actually anterior column fractures. Even though the previous X-ray shows very benign, congruent, very nice, but if you look at this part, you see there is a gap, probably more than 2, probably I think it's 5 millimeter here. So what do? You need to fix. So as in this case, I use ilioinguinal approach because I'm very familiar with ilioinguinal approach, where you can put plate here and put screw and screws on the other side because of the sacroiliac diastasis. I just put 2 plates here. Just why don't I operate this? Because this patient has got polytrauma, so I thought I want to minimize the operative hours. So these are fractures after 1 year. You can also approach this fracture by using so-called modified stopper plus lateral window of the ilioinguinal approach. So this is the ilioinguinal approach where you have a long line here and you have to identify 3 windows. And it is not easy for newcomers, for the young surgeon. You must have a very good anatomy knowledge and a very good skill to isolate all these things. So I would advise those young surgeons, if you want to learn, you attach to somebody who is senior, who has done many ilioinguinal approach. Case number 2, 45 years old, and the plane X-ray looks benign, but something is there. Can you see the problem with X-rays? Even though it's very important, but X-rays is operator dependent. If the radiographer cannot give a good X-ray, you will not be able to see a good images. As in this case, this is basically a soft tissue X-rays. That's why it's difficult for you to see the bone. If you have a good radiographer, you just do a bone exposure, you will get a very nice X-ray. That's why, in my opinion, you must do CT scan. This is a CT scan, 3D. This is the anterior column, anterior wall. I would like to apologize. I don't have the other views. This is views given to me, referred from other hospital. So this is the diamond shape where I show there's fracture of the superior dome. So what do you do? Using ilioinguinal approach, you buttress this. This is to reduce the anterior column. After you put that, you put plate along the ilioinguinal region. This is something extra where you find intraoperatively there's a fracture. You just put a simple plate. Okay, case number 3, anterior wall and anterior column fractures. So in this case, looks very benign again, but you must do CT scan. Then you see there is a gap, and then you approach using plating 3.5 millimeter reconstruction plate. In our hospital, normally we have been using a lot of synthesis plate because synthesis plate is a better plate where you can easily mold and contour according to the shape of the bone. Whereas the complete is very hard and difficult for you to contour. That is my personal opinion. So this is case we did through IO iguanal approach. Okay, how about this percutaneous anterior column screw fixation? Yeah, for cases where there is minimally displaced, undisplaced, you can do a percutaneous approach with got a good advantage, early mobilization of the patient, and it can be done two ways, from the so-called anterior grade or from the front. From the front is like this, retrograde. But it requires a good radiographer to give you good images, and you have to have a good II machine. If you don't have II machine, you will find it very difficult to get a good image. But if you have a good images, a good radiographer, yes, please, by no means, please proceed. Patient will be beneficial for early mobilization. But don't forget conservative treatment. If you have undisplaced fracture like this, what do you do? I normally won't operate. I don't even consider percutaneous. I just put the skin traction, skeletal traction, maybe for 2 to 3 weeks. Then you do skateboard exercises for 1 week, and then you discharge patient. But it's very important to avoid non-weight bearing, to avoid weight bearing for at least 6 weeks. And that has been my practice. So thank you very much. Shall I proceed to the second lectures?
Yeah, please.
Okay. Again, I will thank you to the organizing committee for giving me opportunity to present second lectures, which is posterior wall and posterior column.
We just have 7 minutes, Dr. Dato.
7 minutes?
Yeah.
For this lecture?
For the two topics is
never mind.
Just 30 minutes. Yeah, please.
The next. Okay, again from Smart Hospital, this is example of acetabular fractures. We have posterior wall fractures, these two cases. Then you have posterior wall and posterior column can occur with transverse fracture, T-shaped fracture by columnar, and the treatment will be very much different. And sometimes this can occur with hip dislocation. So undisplaced treatment, I do conservative like skeletal traction, limb abductor 45 degrees to offload, pressure, traction for 3 weeks, skateboard exercises for 1 week, non-weight bearing for 6 weeks or more. And this has been my practice in my hospital. We call it vector traction. You put lateral traction 1 year, then another supracondylar pin traction, and you start with 5-5. In case every 2 days by 5-5 until dislocation is reduced. That will make your operation very much easier. Indication, hip dislocation with fragment more than 2 cm, intra-articular fragment like this one. And you have a small fragment but hip is dysplastic, I will operate and present of postural instability. Approaches can be done by cocker ligament back. Can be done with lateral position or in prone position, but I normally use lateral position. So fixation, normally we use spring plate with single plate or double plate. For a double plate for posterior wall plus posterior column, single plate for posterior wall. So when you do a cocker ligament back, this is a quadrilateral femoris. Beware of the vessel here going to the femoral head. It is important for the femoral head blood supply. First case, 35 years old, MBA, posterior wall and posterior column. You can see from here, this is the wall. But if you use this scan, you can see even the column. So what do? We plate. Because column and wall is fractured, we use 2 plate plus 1 spring plate. And spring plate is a concept where you put a small plate here, a very specialized plate from TNT, but you can contour it from the wanted tubular plate. When you cut at the end, it becomes spring plate. So his second is 27 years old. This looks like a fracture. Shape is sublux. Probably column fracture, distraction, good reduction, but you need CT scan. Then you can see, apologize, difficult to see because the X-ray is not clear, but this is a posterior column fracture. What do I do? Cochlear ligament back, spring plate, and double plating. Okay, case 3 is basically posterior wall fracture. A lone fracture, still we need CT scan. You can see a nice posterior wall from 2D, 3D, and also from sagittal view. Approaches is one single plate plus spring plate. And this is a schematic example of where you put the plates over the posterior wall fracture. Thank you very much.
Thank you, Dr. Dato Abdul Rauf bin Ahmad, for the great presentation. So we will proceed to the next presenter, Dr. Gibran Tristan Alvarian. He will deliver the topics about transfer fracture patterns. Dr. Gibran Tristan is the orthopedic trauma consultant from the Hasan Sadikin General Hospital and Universitas Pajajaran, Bandung. And time and screen is yours, Dr. Gibran, for the next 15 minutes, please.
Thank you, dear moderator. Greetings, everyone. Thank you very much for having me here. It's a great honor for me, and all the previous presentations have been very top-notch, so I will try to keep up and not disappoint. So my topic is about the transverse fractures of the acetabulum. I'll try to keep it short and simple due to time constraints. So transverse, pure transverse is one of the elementary fracture patterns, and it's actually by epidemiology is considered second most common. And it can be associated with the posterior wall fracture as well, which makes it a transverse with posterior wall. And by epidemiology, some papers say this is the third most common fracture line overall. So even though it looks relatively simple, but it's actually quite challenging to achieve a good reduction due to the behavior of the fracture. And if you see that a transverse fracture is a fracture that goes through anterior column and posterior column. So if you see the X-ray, you will find a break in the anterior column, a break in the posterior column. But for the residents in the audience, it's different from both columns. Even though it involves both columns, it's not a both column fracture. So don't mix it up. The both column fracture is a different entity altogether, which will be presented by Professor Chiracai after this. A transverse fracture involves both columns, and depending on where its position, it can be divided into infratectal, juxtatectal, and transtectal, based on where it is in relation to the acetabular roof. And knowing where the fracture line goes, where does it exit anteriorly and where does it exit posteriorly, is very important, because it helps you decide your approach. It helps you plan your reduction maneuvers and all the associated difficulties. Now, the mechanism is, of course, a force transfer to the transfer through the neck, head, and up to the acetabulum in various variable factors based on the position of the femur on the time of impact. Most are lateral forces, lateral compression injuries, but sometimes it could be a fall from height where the limb, the femur is in extension and the forces are transferred through the acetabulum. And it creates a fracture and displacement, which is quite typical. You will find that there is a medial displacement. So the fracture divides into two parts: the upper or the proximal ilium fragment and the lower ischopubic fragment. And the lower ischopubic fragment, it's medially rotated or internally rotated with hinge on the symphysis. Now the ilium part can be either undisplaced stays where it is, or it's tend to be slightly external rotated or even quite severely external rotated, associated with sacroiliac joint disruption or widening. The head fragment can be attached either to the ilium fragment, to the acetabular roof, or it follows the medial, it follows the ischiopubic fragment to the medial, creating what some may say the central dislocation. Now, if you see this X-ray, this shows that the internal rotation of the ischiopubic, medially displaced head, and the slight external rotation of the ilium. And you see this from the Judae. This is why Judaes are important. You can see how the fracture line exits posteriorly, quite near the notch, and anteriorly, quite at the middle of the acetabulum around the tectum. So, yeah, this is the typical findings you will find in transverse fractures. And treatment indications, most of these would need surgery. You need to consider the hip joint stability, which you can use the roof arc angle measurements to decide. You need to check the joint congruency, displacement, whether it's below 2 mm, which is considered the cutoff point, intra-articular fragments, marginal impaction, and with posterior, with transverse and posterior wall fragments, the size of the wall fragment is also important, and whether there are signs of sciatic nerve injury, which could be caused by impingement from the fracture fragments. Some undisplaced fractures like these on the screen here may be treated conservatively, but any displacement more than 2 mm, you would the patient would be better doing surgery unless there's absolute contraindication for surgery. Now, the techniques of osteosynthesis, there was some biomechanical studies, and they found that fixing both columns is a must to achieve the most stable fixation that allows the patient to do weight bearing earlier. And commonly, this is the common pattern of fixation. You use a posteriorly applied reconstruction plate and an anterior column screw. Or there is also option doing a posterior and an anterior plating if you have no access to anterior column screw in your hospital. And one issue is, how do you approach this? Do you approach this from one side or two sides, or one approach that can encompass both? Well, most of the transverse fractures can be treated by this Kocher-Langenbeck approach from the posterior. It may be considered a workhorse for this kind of fractures. It provides direct visualization of the posterior column and any wall fragments. However, it only gives you finger palpation of the anterior column. So reduction of the posterior you can see directly, but the anterior column you only feel with your fingers, and you don't manipulate it directly. You manipulate it in one unit with the posterior column. So in some cases, it may be difficult to reduce the anterior column from this approach. Anterior approaches, we can use the anterior interpelvic or the modified stoppa for pure transverse fractures. This can work, but if you have a wall associated wall fracture, you need an additional posterior approach. And it gives you direct visualization of the quadrilateral plate. You can directly see the fracture line in some cases. And if you are able to reduce anatomically, you can fix with the anterior plate with posterior column screws. Now, there are, as mentioned, approaches that you can expose both columns, reduce both columns with one approach. This is one, the extended iliofemoral, which was advocated by Letournel for late cases or difficult cases. It exposes the whole acetabulum, the outer surface of the hand pelvis. However, as Professor Tiracha has mentioned, I think this is the history, because the rate of complications and morbidity is, of course, quite large. Even though you get a major exposure of the fracture, you open up a risk for complications. Some surgeons, I think Dr. Mario Skiel from Switzerland, are advocating this, doing this fracture using a surgical hip dislocation. So it gives you direct visualization of the articular surface without the risk of doing an extensile iliofemoral. So but it needs experience to do this well and safely. But the advantage is you get simultaneously manipulation of both fractures at the same time. So, and you can see the reduction and the marginal impaction directly under your visualization. And reduction techniques, you can use, these are some of the reduction techniques. You can use a shunt screw, put in the ischiopubic fragment, you derotate the fragment, and then you can use pointed clamps, Weber clamps, or you use these pelvic clamps that you can slide in from posterior through the notch, one tine in the posterior column and one tine in the anterior column. And then my favorite is actually the Ferrabooth clamp, which you can get a good grip and control the movement of your fragments. But most of the time, actually, it's not only one method. You need several methods. Like in this picture, you have a Ferrabooth clamp going here, you have a pointed clamp going the other way, a shunt screw. So yeah, because sometimes when you reduce one side, you get a good reduction of the posterior column, your anterior column opens up. And you try to reduce the anterior column and your posterior column opens up. So you need to play a bit with your reduction maneuvers. The outcome is, this is some summary of some reviews of the outcomes for transverse fractures. Generally, they get good outcomes. The functional scores are excellent, even though the anatomical reduction rate is actually surprisingly not as high as we hope, which it shows how these fractures can be difficult to reduce. So I'll share one of my cases. This is a 41-year-old male who actually came to my hospital, referred after 1 month of the injury pattern. So if you see, I'm sorry, I jumped through the 3D CT. We should have, I don't have the good picture of the X-rays and axial CT scans, but you can appreciate here that there is an anterior, this is the anterior fracture line extending posteriorly just below the notch. What's interesting is in this case, you have an SI joint disruption as well, which is quite, I think it's quite severe because it leads to a slightly posterior and upwards displacement of the SI joint. And you can see here the posterior fracture line exits here. The wall is intact, so it's a transverse fracture. And what complicates this is because this is 1 month. And yes, so I expect the reduction would be difficult. And so my thinking is, my plan of action is, I need to also release the fibrosis from the fracture fragments to properly mobilize the fractures. Starting from the SI joint, because I need to get that ilium fragment down where it should be, so it doesn't cause difficulties when reducing the.
Gibran, sorry, 3 more minutes. I
Yes.
think.
Okay.
Yeah.
I'll speed up. So my plan: release, mobilize, and reduce the SI joint, and if possible, release, mobilize, and reduce the anterior column from the same approach. And if possible, also reduce the posterior column from that anterior approach. And if not, if I cannot get a good reduction of the posterior column, I will do a separate posterior approach. So that was my plan. So for the anterior, I did a modified iliofemoral approach, where you do an osteotomy of the ACIS, and then you push down all the muscles to the medial, so you get good access up from the SI joint down to the anterior column fracture fragment. And then I did an additional intrapelvic approach, or the modified stoppa, like in this picture, because I wanted to fully debride the fibrotic tissue from the fracture. And if you can see here, after I was trying to debride all the fibrosis, mobilize the fragment, and here you can see part of the head cartilage. So the fibrosis is gone. So I proceeded. I used the Ferrabooth. As I told, I'm very keen on using this. I reduced the anterior column. put a plate there to hold it there. And then I tried to reduce the posterior column from this approach. I used a combination of ball spike pusher here and pelvic uneven pelvic clamps, one tying in the outside of the hemipelvis, one tying in the quadrilateral plate. But for some reason, I wasn't able to get a good reduction. I couldn't get a good anatomical reduction, and I cannot read the fracture fragments quite well. I was not confident that I reduce the posterior part, and so yeah, so I stopped the anterior attempt, put in an iliosacral screw to fix the SI joint, and then I moved to the posterior and did Kocher-Langenbeck approach, and you can see this is the fracture line after I cleaned out all the fibrosis, mobilized, and there was a slight tear of the capsule that I was able to see inside the joint. I don't have the picture, but it's there. And then again, I use this variable clamp to achieve reduction, and then use plates to fix. So this was the final fixation. I'd like to think that I get a quite reasonable reduction. The joint line looks quite congruent, and this is on his follow-up around 1 year later. The joint is still there. No signs of degenerative arthritis, and the patient is fully weight-bearing, quite happy with his functional result. Okay, so that brings me to the end of my presentation. Thank you for your kind attention.
Thank you, Dr. Gibran. We will hold for the question until the last presenter in this session, Prof. Terachai, give the presentation. Okay, we proceed to the next presentation. Will be delivered by Professor Terachai. It's about both column fractures. Professor Terachai, you have 15 minutes to give the lecture.
I will try to finish.
Yeah,
okay.
please.
You see my screen?
Yeah, it's clear.
Yeah, both column fracture. Maybe somebody said this is the most difficult one. Yeah, but sometimes the pelvic injury is more difficult than this case. What is both column? How to diagnose? Indication, surgical approach, techniques, step of the reduction is like quite constant for the step of the reduction. What is the both column? As Gibran said, this is a misnomer because this is the floating acetabulum. That means you have this is the intact to the axial skeleton, but there is no fragment of the acetabulum that attached to this intact skeleton. So we call this the floating acetabulum, or no portion of the articular surface remain attached to an iliac wing. Diagnosis. Yeah. What is the spur side? The spur is the most caudal part of the intact ilium. And you have the sliding of the distal part or the acetabular part. It's best seen on the obturator oblique view. This is the obturator oblique. This is the spur sign. And when you look at the CT obturator view, yeah, you see this is the intact. It's intact ilium. And this is the fractures that's sliding, yeah, to separate the acetabula from the axial skeleton. Again, I show these pictures. This is the associated acetabular both column fracture. That means if you have some of this condition, it shifts the whole of the articular cartilage or the joint medially. Then maybe we call this a secondary congruence that you can make as conservative treatment, and the result will not so bad. However, yeah, you have to make sure that the acetabular labrum is intact, yeah, and all the fragments remain congruent to the head, no remit hip motion, yeah, and be careful. In some case, you have some shortening, like in these pictures, yeah, the acetabular congruent is best, is good, but you see the movement of the medial shifting of this acetabulum that's caused the massive shortening of the limb. Instrument. Yeah, I have to emphasize again that you need all reduction forceps, and this is the key of the success. The collinear reduction, you have to have these asymmetric clamps. That means one time is in the acetabulum and one time is outside. And that's, you reduce the medial wall and the very long drill bit to make the column screw fixation. The principle is, again, let's start with transfer to the axial to the hip joint, anatomical reduction of the weight-bearing dome. Okay, you have to understand the step of the reduction and the fixation. If you understand, both column is almost the same. Yeah, just some of the variation. First, reduction of the anterior column to the stable fragment. Yeah, you see, this is the intact or stable fragment. This is the anterior column fragment. Yeah, you have to reduce it. Now you have some part of the acetabulum that attached to this stable fragment. Now this is the posterior column fragment. You have to reduce it to the stable fragment of the anterior column after you reduce. And then you make a stable fixation. This is the key of the success. The traction, the lateral traction, this is very helpful because most of the case, the head is shifting to the medial side. You just put this and you make a lateral traction. Some parts of the capsule will pull the fragment back and partial reduction is achieved. Yeah, you can see from here. Yeah, reduction of the anterior column. Yeah, you can use many clamps. Yeah, this is the intact fragment. Yeah, we reduce first. This one, as I showed you before, and you fix with the screws. Now you reduce the anterior column to this intact fragment by use many of these ball spike pusher, or sometimes you use the plate to pushing down the anterior column fragment. Okay, like in these pictures, we already show you, reduce to the intact fragment. Yeah, you see the X-ray here. Now we reduce the posterior column to the intact anterior. Yeah, as I tell you, this is the asymmetric cam to reduce the medial wall. Yeah, or you can use this special reduction forceps from the modified stop bar approach. You have to have the special one, not the simple Weber clamps. Yeah, this is the intact anterior column after reduction. Right now, we bring the posterior column back. Here you see this is the asymmetric cam, and we fix the anterior column to the posterior column with these long screws, or we call the anterior to posterior column screws. Yeah, like these pictures. Yeah, you see this is a posterior column. Yeah, so plate or anterior column screw. Yeah, you can fix reduction of the anterior column. Now, fixation of the posterior column screws by this one. Yeah, and medial buttress or the infraacetabular screws. This is the step of the fixation. What instrument you have, the surgical techniques or the experience. Surgical approach depending on the fracture configuration, degree of displacement, surgeon preference, what you have in your hand, exposure of the iliac forceps, iliopectineal eminence, pubic lemma or symphysis, which area you want to approach. Most of the case sometimes is not the same. Some part is iliac wing more displacement, some part is in the iliopectineal eminence more displacement. Then you can select what approach. I will show you the different approach. Ilioinguinal, modified stopper, lateral window, pararectus, lateral window. you can make the additional ASIS osteotomy for the lateral window to see more on the medial side of the lateral window, or sometimes combine anterior posterior approach. Ilioinguinal, you can see this area. Anterior or the stopper approach, you see this area. If you want to see on the lateral, you need a lateral window of the ilioinguinal. Then you will see more of this approach. Another approach now described by Q, the show is the pararectus approach. You can see very well of this medial column, medial quadrilateral, some part of the iliac fossa. You can see more with this modified stopper compare. Okay, I show you this case. I know Prof. Kong is here, Prof. Kong from Singapore, 2002. He was with me some times ago, and we have this both column fractures. At that time, we don't know how to do it in the very elegant way at that time. We have the both column here. Yeah, we cannot reduce the back from the front, so we use flip-flop or the combined anterior and posterior approach. Yeah, this is the anterior fixation, and then we flip the patient to make a posterior fixation. Okay, you can see this is the anterior column fixation by the ilioinguinal approach. But the posterior still displaced. We don't know how to reduce it from the front. So at that time, we make a posterior approach again, and we do the Coker-Langenbeck and fixation here. Yeah, it's a good reduction, but you see many of the implant is there, and we need two approach. But it's 20 years ago. Now we have a better option. You see, this is again the both column approach, both column fractures. Then we can use the ilioinguinal approach. This is a classic. Yeah, I will show you. This is the external oblique sheath, inguinal ligament. And we open up it, and we explore the inguinal canal. Yeah. And this is the lateral window, iliopsoas with the femoral nerve is here. The classic, yeah, we have three windows of the ilioinguinal approach, and we move under these structures. Yeah, and this is a fixation from the anterior lateral window. You can see from here down to the symphysis pubis. Now, how to reduce the posterior column? You need this collinear forceps and this asymmetric clamp to reduce the medial displacement, and you pull it up to reduce the posterior to the anterior column. Yeah, and then you can fix it from this approach. Yeah, this is the posterior column displacement. Now we reduce and fix with the screws down to the posterior column. Yeah. So we can fix posterior from anterior approach at the same time. One approach, but you need very good reduction tools. And this is the intra of X-rays. Good reduction of the anterior column and posterior column now. Yeah, and this is the post-op X-ray. Now I show you another approach. Yeah, this is again both column fractures, different approach. This is the modified stopper and the lateral window of the ilioinguinal. Yeah, you can reduce the anterior column or anterior fractures. Yeah, now you fix it with the LC screws. This is the, we call the LC2 screws to fix the anterior to the posterior of the ASIS from PSIS. The next is reduce of the posterior column displacement is here. Yeah, you see the posterior column displaced with the quadrilateral plate. Yeah, you can reduce by the stopper approach. It's difficult to show all the X-rays, but this is how we reduce through the window. This is the AIP approach to fix the medial wall of the acetabulum. And this is the fixation reduction post-op X-ray. Maybe this is the last one. This is again the both column fractures. You see the floating of the acetabulum here, medial wall displacement. I show you again this is the modified stopper and lateral window. This is published by Saki in JOT 2016. He compared, this is the without osteotomy, ASIS, you can see to the SI joint. But if you make an ASIS osteotomy, now you can approach more distal and more medial. That means you can see the whole of the inner part of the ilium up to the superior of the dome. And this is the reduction by the chain screws, anterior column fixation, posterior column fixation again from the front. This is the collinear forceps to reduce. You have the medial fragment here, which is very simple to buttress by the stopper approach, just pushing the medial wall back. And from this window, you can reduce and fix the anterior fractures. And this is the final fixation. And the results. This is the last one. It's a very comminuted medial wall and the ilium fractures. But the lateral part of the ilium is not displaced. If you look from here, it's very minimally displaced of the lateral ilium here. The fracture displacement is on this acetabular dome. So this is a very good option for
Sorry, Professor Terachai.
Yeah.
1 more minute.
Yes.
The time is 1 more minute.
Yes. Maybe not familiar. This is the pararectus. It's just directly on the anterior of the acetabulum. Gives you some ideas. You can go here, stopper, and the lateral window and the pararectus if you need. This is only the pararectus. You can reduce. And fix the anterior and posterior column here with the only single approach. You see the anterior to posterior column screws. So take home message, diagnosis, evaluation, you have to know how to call what is the both column fractures. Selection appropriate surgical approach, which area you want to see. I show you many options, but I think you cannot do it. However, if you want, you have to train, you have to do it in the cadaver. And I show you the reduction steps. It's almost the same in every of the both column. And you need some extra very long screws. Thank you very much.
Thank you, Professor Terachai, for the excellent lecture. It's very informative lectures. So I invite Dr. Dato Abdul Rauf, Dr. Gibran Tristan, and Professor Terachai to switch on the camera and we enter to the Q&A session, discussion session. And I invite Dr. Raymond Win to ask the question directly to the presenter. Please, Dr. Raymond Win. Can the host okay, Dr. Raymond Win. Can you hear me? Yeah.
Yes, doctor. I can hear you, doctor.
Please direct to who the question.
Yes, doctor. Thank you for the opportunity. For my question, I would like to ask for Dr. Gibran, doctor.
Yeah, please.
Yes, doctor. Thank you. Thank you for the presentation, Dr. Gibran. In here, I would like to ask in the transverse acetabular fracture cases, what is the best approach for the surgeon who has a little experience in these cases? And then regarding the advantages and the disadvantages of the approach. And then what is the most common pitfall in that approach, doctor? Thank you.
Can you catch the question, Dr.
Yes,
Gibran? It's too
thank-
fast. Yeah.
No, I
Please.
can. Yeah, thank you very much for the question. Interesting question. So I think the one thing we need to mention, if you are inexperienced when treating these fractures, I suggest you ask help. Ask for help from someone who is experienced in doing it, because it's not that easy. It's quite difficult. But I think, as mentioned, you can reduce from the posterior approach, from the Cocker-Langenbeck approach, but you really need to be able to visualize where the fracture fragments is. And if you are a beginner, maybe you need to prepare yourself to do two approaches. Doing two approaches is much more easier from trying to do it all from the posterior. And the pitfalls, if you're going to for posterior, of course, is related to the approach itself. If you don't do a proper Cocker-Langenbeck takedown as it's described by the technique, you may risk femoral head osteonecrosis if you are not careful about where you cut your short external rotators. And when you are putting in your reduction tools through that very narrow space, if you don't know what you're doing, where you're clamping, you could injure some very dangerous things that you do not want to injure. And one thing, if I need to mention, if you find a fracture pattern that leads into the greater sciatic notch, and this is like a spike there, be prepared to find some bleeding there, because that is where the superior gluteal artery branch will come out, and you may find some bleeding there. If you're not prepared, you may panic and don't know what to do. I usually try to pack the area, leave it for 15 minutes, pray, and check again. Usually most of the bleeding can be controlled from there. I think that's what I can answer. Maybe other speakers can give their opinion.
Please.
Maybe I can give some advice. I agree with Dr. Gibran. Transverse fracture can be very difficult, especially if it displays a lot. Then you look at the displacement, which is more anterior or posterior. If the displacement is more anterior, you go anterior. Because even though if you go anterior, when you reduce the anterior displacement, more or less posterior will follow. And to fix the posterior column, you can use a long screw from the anterior. If the displacement is more posterior, you go posterior. And to check whether reduction is good, you put your finger in the sciatic notch and feel it. Feel this way. If it's okay, then put 2 plates from behind. Thank you.
Professor Terache, any comment for this question?
For the young, I think okay. You have to know or assist some of the master before you do it by yourself, because it cannot read from the book. It is you say every faculty said you palpate, you can move your fingers from the back to the front, but you don't know where it is if you don't know how to do it. The second is, I always have the plastic bone in the wall. Yeah, you can use this. I always taping. I think Gibran see what I do when I do the pre-op planning. I tape all the acetabulum with the paper tape, and then I draw all the fracture line. Yeah, and you plan where to apply the clamps. Yeah, sometimes it's possible, but inside this operation, sometimes you cannot make it because of the soft tissue. But you have to see how, where to clamp it, where to put the time of the clamps. Yeah. The fractures is not all the same, yeah, but you can have some ideas. How can I reduce the fractures? Yeah, and for the posterior approach, if you want to go to the anterior or the quadrilateral surface, I think you need special periosteal or the cup elevators to clean the area. Yeah, to clean up the obturator internus muscles from the back. Yeah, I have to have this curve of the cup. Then you can turn it and you clean the fractures of the quadrilateral from the back. Yeah, this is a special tools, and then you can use your fingers move. Yeah, if you have short index, you cannot do it. Yeah, because it's very far away. My fingers, I can follow the fractures. I can go to the superior rami. Then I feel all the fractures on the front before I make a fixation.
Yeah.
Yeah.
Okay. Thank you, Professor Terachai. And the next question is for Dr. Dato Abdul Rauf from Korea Maulidia. Could you please share tips and tricks how to avoid disrupting the femoral head vascularization during Kocher-Langenbeck approach for posterior column or wall fractures? As you said in your presentation that we should be careful about the vascularization around the short external rotator, and how many percent if could lead to a vascular necrosis. Please, Dr. Dato Abdul Rauf.
Thank you for the question. Posterior approach Kocher-Langenbeck is famous for causing EVN of the femoral head. You're not careful. So when there are a few tips when you do Kocher-Langenbeck, make a big incision so that you can see all the muscles, and then we can put traction lightly. Second, you look for the borders of quadratus femoris muscle. Try not to go near it, because if you operate enough, you will see a nice blood supply near the borders of quadratus femoris muscle, which will go into the capsule and into the femoral head. And then therefore, when you cut the short rotatus muscle, try not to cut too near to the incision. I normally cut 2 centimeters from the incision. And this can be repaired easily. If the fracture is quite high, you may not need to cut the lower hip rotatus muscle. After you cut maybe the first 2 rotator muscle, the rest you can just move and put under the muscle. That's the way how you want to reduce the injury to the vessel, important vessel that supply the capsule and femoral head. And then regarding percentage of AVN, I think in displaced fracture is more than 50%. Patient will develop AVN.
Okay, thank you, Dr. Dato Abdul Rauf. And the last question is for Professor Terachai. In comminuted fracture patterns, in pelvic acetabular fracture, what are the indicators of good reduction? If we find a very comminuted fracture, how far that we can tolerate it, degree of displacement? Thank you very much. From Benedictus Deriano.
Yeah,
please.
It's difficult to say how much, but it's depend on the area of the displacement. Yeah, if you have a dome, impaction of the dome displacement that you did not reduce, even in the posterior wall or the posterior column fracture with the Gauss side, you know the Gauss side, that means the articular impaction. If you don't reduce even 2 millimeters, you get the bad outcome. But for the both column fractures, for the young or the starters, the medial displacement of the posterior column of the wall, yeah, maybe sometimes it's 5 millimeters, but it's the medial part of the dome. So it's maybe not the cause, the osteoarthritis. So it depends. If you have the dome, try to do reduction of the dome impaction. Look at the 2D X-rays always. Yeah, if you have the impaction, you need to treat the impaction. There are 2 or 3 fracture type. Yeah, posterior wall. Yeah, posterior wall with the posterior column and the anterior column fractures. This has a high chance of the articular impaction. Yeah. Okay.
Okay, thank you, Professor. And maybe for the last time, I will ask the Dr. Taufik Akbar, who is raised hand. Please, Dr. Taufik Akbar, tell the question directly to the presenter, please. Dr. Taufik Akbar. Yeah.
Yes, thank you very much, Doctor.
Yeah.
I actually have a question for all of the panelists because I actually got a case of a central dislocation of the hip, sir. And when I'm still confused about the principle actually, when the central dislocation happened, the hip was protruded into the pelvic area, right? So it's really commutative, and when you fix the commutative part, what is the principle? Do you like put the pieces all together, or do you just bridge the pieces so that we can have some good callus for the articular surface area? So what is the principle to restoring the articular surface for the central dislocation of the hip, sir? Thank you very much, sir.
Yeah, thank you, Dr. Taufik. Maybe Professor Terachai first.
Yeah, the one you mentioned, that's the medial dislocation of the hip. Most of the case is the anterior column with posterior hemitransverse in the elderly, or the both column fractures, right? If you have this combination, usually you have the very thick of the periosteum on the pelvic brim. Yeah, when you cut it, yeah, and you make a traction, lateral traction of the femoral head, this is the very tight ligament that will reduce the fractures. So sometimes I preserve some part of this to hold the bone piece together. Yeah, but you cannot fix anything because it's a comminute on the medial of the pelvic brim. So you just bypass. You can push it by the plate. Yeah, you reduce and use the plate to bridge these fractures. You cannot reduce all the pieces. However, when you reduce, get the length of the anterior column correct, then you reduce the medial wall or the posterior column or the quadrilateral plate. Yeah, and then you can fix anterior to posterior column screws. Yeah, you have to understand all the anatomy, and then you know, okay, I will put these screws. How to put it, that's another technique that you have to learn. Yeah.
Okay. The second one, maybe Dr. Datuk Abdul Rauf, please.
You are
Still
mute,
sir.
sir.
Yeah.
Sorry. If you have a very comminuted fracture of the quadrilateral plate, very comminuted, it's confirmed with a CT scan. Or if you're not sure, I suggest you do 3D printing. You can see a nice small pieces. If it's very comminuted, I normally treat conservatively with vector traction. In most of the time, I will able to reduce, but you'll be surprised. You need a very heavy traction, maybe more than 10. But I have used up to 30 kilogram traction. It reduced well. And if patient complain of pain, you refer them to EPS pain service team. Keep it there until it harden by 2 to 3 weeks. Because the main thing is to reduce the wall so that next time if you have OA, osteoarthritis, you can do total hip easily as compared to if the wall is away from the hip joint. That is my opinion. But if you think you can see few big pieces, you use the big pieces, and I normally use butter plate. Butter plate means you contour like that according to the shape of the. You buttress the quadrilateral plate and then you screw it. And I've done that quite a lot, and it's quite useful to prevent redisplacement. That's my opinion.
Thank you, Dr. Dato Abdul Rauf. And last not least, Dr. Gibran, please.
I think our experts have answered the pointers. I agree that if I had a very cumulative wall, I would try to, if I had to go and fix it surgically, then my priority would be restoring the columns so I can get a good read, and if possible, reduce the large fragment as much as possible, bridge it, and hope for the best. As Dr. Dato Abdul Rauf mentioned, those buttressing plates are very useful. You can fashion them with maybe 1/3 tubulars or your recon plate, or if you have access to those pre-made, prefabricated special plates, which are not available yet in Indonesia, actually, I think they can be quite useful.
Okay.
Yeah. We use many recon plate or synthesis plate. Just contour it and then push it. You don't need to buy a very special plate. Very expensive.
Yeah.
Okay, thank you.
Yeah. Okay. I think it's clear enough for the question, for the answer. And it's the end of the second session. We will thank you so much for the presenter, and we will proceed to the third session. Thank you very much for the presenter.
Thank you.
Thank you. Assalamualaikum.
Waalaikumsalam.
Okay. The next session will be presented by Dr. Harisuko Wihandono. The topic is about pelvic acetabular fracture in low resources setting, my experience. Dr. Harisuko is a senior staff orthopedic trauma consultant in the Kraton District Hospital in the Pekalongan, West Java. And he had so many difficult cases that he will share with us. Before the next 15 minutes, Dr. Harisuko, sorry for the delay. Time and screen is yours, please.
Thank you, Dr. Imamul, for this opportunity. At first, I would like to say thank you to Dr. Edi Mutamsil, Dr. Bambang Gunawan, and all of the professor distinguished guests. In this session, I hope we are not sleepy because this is the last in the end week in the last session. After we get the best and interesting lecture for the operative treatment for the pelvic and acetabular fracture, I get the job to present the case report about the conservative treatment is any place for the pelvic and acetabular fracture, especially in low resources setting. At first, I hope we should be always remember about the anatomy because this is the first basic knowledge must be. We know how to diagnose the patient, how to know the dangers of the patient, to choose the approach of the patient if we operate, and how to reduction of indirect reduction of this fracture if we treat with the conservative treatment. Second, we must be know about the biomechanics of the trauma. We know the anteroposterior compression, lateral compression, and vertical shear. But usually the patient not only one type of the biomechanic trauma. Usually 1, 2, or 3 bimicrotrauma directly in one time. And then, as we know, like the professor mentioned, we must be know the classification, many classification we can know. This is for important how to make the decision maker to treat and how to know the prognostic factor for this patient. So the question is there any place for the conservative treatment of the acetabular and the pelvic fracture? This is the original article, original journal, mentioned that in the tile tip C, minute with a success rate of the 81.4%. Conservative treatment has been considered as safe as and effective in tile type A and B fracture. Although the popularity of surgical treatment in tile type C fracture has been increasing, when the surgical risks are considered, conservative treatment may be also alternative treatment method. So there is any place for the conservative treatment. The second journal is the prognostic of the functional outcome of the patient with unstable pelvic ring fracture, comparison of short and long-term prognostic factor. In this multiple logistic regression analysis, identified fracture of the lower extremity, conservative treatment, nerve damage as determinant of unsatisfactory short-term functional outcome, and nerve damage and poor radiological result as determinant of long-term functional outcome. In patients with unstable pelvic ring injury, fracture of lower extremity, conservative treatment, and damage nerve damage influence short-term functional outcome. While the nerve damage and pelvic ring displacement over 2 centimeters, negative affected long-term outcome. This is the principle how we must be get it to whatever with the method we treat the patient, operative or conservative. This is the first case. Before first case we mentioned, I would like to remind about the ATLS for the damage control pelvic injury, because usually the pelvic injury is not the simple impact, but it's usually the high impact and the crash impact. They usually with the hydrodynamic compromise. This is the algorithm to damage control the pelvic injury, as all of us read in the LTLS book. How to control the hemodynamic unstable pelvic fracture? We can look in this algorithm. At first, we resuscitate with 2-liter crystalloid with the wrap pelvic seat or pelvic binder for this. And after that, we take the X-ray, pelvic, thorax, and G-spine X-ray. After that, if there are any suggestion of the abdominal trauma, we consult to the digestive department, and if there is no, we take the CT scan for this patient and ongoing thrombation. This is requirement or not. This is after that if the plan we make planning for this patient. This is the example of the pelvic band-aid. We many choose we can choose. This is the case one patient with traffic accident with ex-photo like that. We treat like that. The history of patient, this male, 54 years old, and typical left of the prevent. This is the traffic accident. Primary survey, clear, stable, and C-spine. Read spontaneous with respiratory rate 24, blood pressure 105 per 70 millimeter Hg, and pass when this is the pre-shock sign. The GCS is compost mentis, people is shocker. Secondary survey, abdominal is normal limit. Pelvic region, skin intact, tenderness, and from hip is limited to pain. In emergency room, hemoglobin content is normal, but in ICU, the hemoglobin content decrease. This is the X-ray. This is the closed fracture with non-stable open fracture with non-stable hemodynamic, azotemia, increase for liver enzyme. In this photo, with the symbiosis, more than 2 centimeter with posterior word sacroiliac joint disruption. At first, the APC span control and resuscitation, pelvic sling, and we care in intensive care unit and ongoing blood transfusion. J2 pelvic sling, it is the result X photo. And we look the hematuria and we consult to the urology department. They make the cystography, and this open to become open again. This follow up this patient, the 5 days, this position of the fracture displaced again. We take the skin traction for the left femur, and after day of the 11, the X-ray is in the distance of the symphysis of pubis less than 2 centimeter. And this is the 3D CT. This is a little bit displaced for the symphysis pubis. This problem of this patient, close open book pelvis, vertical cell with the compromise of the hemodynamic. Sign hypertension and hemorrhagic shock, acute hepatorenal dysfunction, anemia, and thrombocytopenia. This is the result for this patient. He can walk with little bit limping, but no pain seriously. The second case, the patient male, 40 years old with pelvic open book vertical chair, comminutive with right costal fracture, contusion thorax, and hematothoracic, pre-shock hemorrhagic and hematothorac and anemia. In emergency department, we primary survey, ABC, oxygen, pelvic sling, IV line, DC, and pelvic raise. Secondary survey, we take the USG abdomen in normal limit, the thorax photo, fracture of the costae, multiple and right hematothorax. The hemoglobin decreased to 7.3, and after we give transfusion PRT to column become increased to 11. This is the photo.
Sorry, Dr. Hari, 3 more minutes.
Okay. This is the X-ray for this patient. This is community fracture and the vertical sling from this patient. We treat the pelvic bandage, CT scan pelvic, and transfusion. This is the result after 3 days. And for this, the photo like that. This is after 21 days or 3 weeks. The patient can sit down and move off of the limb. This is after the 1 month. They start to learn to range of motion of the hip. This is after 4 months. This picture, the fracture become union, but this is into any compromise. The patient can work and patient can work with a little bit of limping. This is X-ray after 1 year. This is the union. This is union. This is what is any compromise in here, but no degenerative changes. This is X-ray after 2 years, and the fracture site is union. No degenerative changes, and patient no leg length discrepancy. You can see it well and can work without pain. Okay. The Harris Hip score is 92. Take home message, medical ethics, 6 principles of the orthopedic treatment, and 4 principles of the fracture treatment by Solarto. Thank you.
Thank you, Dr. Hari. Is there any polling for the
Please.
participant?
Yes, please, Dr. Imamo. So for your
Invite all the participants to answer this polling. It's about 15 seconds, I think, the time.
Okay.
Is there any result? Yeah.
Yes. 90%. This is the true answer.
Is it true, Dr. Hari?
Yes.
Okay.
Exactly. Yes.
Yeah.
So all of us always remember the ethic, how to treat the patient.
Yeah, I think your
Thank
lecture,
you.
it works. Okay, thank you, Dr. Hari, for the very informative lectures. And for the second one, I invite Professor Ismail to tell us, to present it about the complex case example. Time and screens to Professor Ismail, please.
Okay, thank you, Dr. Mamo. So please allow me the share screen first. This one, yeah. Okay, could you see my presentation?
Yeah. Clear,
Okay,
Prof.
thank you. I will like to give 4 cases. This the case number 1, female 48 years old. Actually, this transgender, yeah, because of he is fell down from the height 3 meters, and she is the sleepwalker. Yeah, sleepwalker. And this the pictures. Yeah, there is spine fracture number 1, and also acetabulum and also sacrum fractures. You can see. And also the bilateral vertical sacral fracture bilaterally, right and left. And the calcaneus fractures, metatarsal fractures number 5. And patient also have the distal radius fracture and scapuate fractures. Yes, and this one. So again, with the algorithm, this involving both column. And then there is iliac wing fractures and there is poor sign. So we classify as the ABC type. So the diagnosis, multiple fractures, burst number 1, bilateral vertical sacral fractures, acetabulum ABC types, distal radius, scapuate, fifth metatarsal, and calcaneus fractures. So we have the, there is quadrilateral surface involvement also for the ABC type. What is the definitive treatment? What approach preferable in this case? How about the fixation with the quadrilateral surface combination? You choose the intrapelvic plate or quadrilateral hook plate or buttress plate. Yeah, whatever. So in this case, we do it with the modified stoppa with the lateral window. Yeah. So in this case, the first thing to do, we buttressing, quadrilateral buttress plate using recon, recon plates, 2 recon plates. And then step number 2, we do the iliopubic plate, and number 3 is from the supine, we go back, we go back to the prone position for the postural plating. Why we do not screw? Because there is comminution, and also we would like also doing the lumbopelvic fixation for the vertical bilateral vertical sacral fractures, the X shapes, and as well as the lumbar 1, lumbar 1 fixation. So in this case, we use modified stoppa approach in this patient. This case, according to the pictures, modified stoppa combined with the lateral window is better manipulation field for the instrument and hardwares. Yeah, also make us safer from injury from the artery. Artery if we use the lateral window. So how about the using of the quadrilateral hook plate in this patient? According to the study by Tosonodis et al., have the excellent in 56%, and good in 13%. So anatomical 11, congruent 10, fair, and poor is 6. In this case, I summarize this case is number 1. This is the pre-op and post-op. And we also doing the plating of the metatarsal plate, percutaneous screwing of the calcaneus, and then the percutaneously scapuate, and also variable angle distal radius fractures. And this for the spine as well as for bilateral vertical sacral fractures. And this one, the case number 2, is also fell from the height, 3 meters, but this one is male, 25 years old, with the leg length discrepancy 1 centimeters, and with the fibula fractures, distal radius fractures. You can see there is the epi, inlet, outlet, obturator, and iliac obliques. This is the other pictures. There is no sign of fractures. And this is the 2D and 3D CT scan. You can see the patient. There is also iliac wing, iliac wing. Again, with the we follow the algorithm to classify acetabular fractures. In this case, there is no poor sign. 2 column, there's iliac wing fractures, so it means this anterior column posterior hemitransverse. So with the anterior column posterior transverse, but the patient also associated with the vertical displacement because of the iliac wing fractures. So it give the shortening 1 centimeters. See, and the first thing to do in the emergency, we do the traction, distal traction, to bring it down the level. And in definitive, we do with the modified staupa and with the lateral window. The first thing to do, the step 1 is iliac wing plating to bring it down and plate the iliac wing fractures to make it the level. And then we do the intrapelvic platings, from the staupa approach, And step number 3, we do the antegrade posterior column screw from the lateral window using cannula screw 6.5, and this is the final constructs. So it means our strategy is from peripheral to the articular. So if you reduce the pelvics, it will help you the reduction of the acetabular. So that's the strategy. And then this is the pre and post, pre and post ops pictures. All of you posterior. And this is the case number 3, where female, 54 years old. This because of the motorcycle accident, and the leg length discrepancy is 0.5. So in this case, you can see the quadrilateral surface involvement is so displaced and so commutative, comminution, much comminution. So we can check on the after we do the traction, because to help the reduction of the quadrilateral surface, we do the traction. And this is the CT scan. This one, the CT scan of 3D. See, we can see there is also marked comminution in the backs. Again, this one, the multiple trauma. And then there is left acetabular fractures, judeolaternal ABC on the left, and on the right is the anterior column elementary types, and also head injury and blunt abdominal trauma. How about the definitive treatment? What physician do you prefer for the left quadrilateral surface fractures? Will you choose the quadrilateral buttress plate or intrapelvic plate? So with all of the list of the problems, so we make a match the problem and the strategy that we have to do it. So in this case, because of marked comminution, we not only we would like to reduce perfectly. So we combine the anterior intrapelvic modification to the ilioinguinal approach. So we do ilioinguinal approach, but combine it with the staupa approach. This is mentioned also in GOT. It's also possible to combine your ilioinguinal with the intrapelvic approach. So in this case, again, we do the reduction. I mean, doing the fixation of the iliac wing first, and then intrapelvic plates, and then we do the anterior column screwing for the right side by retrogradely. This is the strategy. Make the reduction of the iliac wing fractures. We can see that there's one, there is plate on the tops, and then infrapectineal plates, yeah, with the pelvic brim, yeah, pelvic brim plates, and then infrapectineal plating, and screwing for the anterior column screw for the right side. This is the pictures, pre and post. And regarding of the quadrilateral surface, we have several fracture pattern. So that's why in every pattern is depend to the classification, the type of the acetabular fractures. So in this case, this is the pattern like this. There is posterior and upper combination, yeah, for the double column, yeah, fractures. And why we choose the infrapectineal plates? Because intrapelvic plates provide better stability to the quadrilateral surface fragment and had the highest load to failures adjacent to the SI joint, rigid fixation. Applying the plate is the same plane as the displacement because you can push down, you press. If doing with the plate, so you can push down and help your reduction. I mean, actually, some the reduction is not so difficult. If of course we do the reduction first with using the clamp, and then with the helping of the intrapelvic plate, help you the push down and press the fragment. And according to the Qureshi, in more than 10 years of his experience, the loss of reduction or fixation with the intrapectineal is not occurred. And infrapectineal plate is the highest load to failures. This is the 1 month follow-ups, but unfortunately, because of massive surgery, there is this is also the complication, adhesion and expose of the screw exposed, and then develop of infection. So staphylococcus aureus infection. So we do the debridement and take out the screw in the iliac, yeah, in the iliac wing. This is the current follow-up. The patient okay, yeah, after 6 months. And this is the last case, male 29 years old with a pain on the right. It is also a motorcycle, yeah, motorcycle with this one, the shortening is 4 centimeters. Why? Because the patient have the central dislocation, and we do the lateral traction as well as the distal femoral traction, yeah, to reduce the central dislocation. And this, so if according to the algorithm, this one with 2 column involved, but there is no iliac wing fracture, so it means this one is central dislocation of the right hip with the posterior wall fracture is the T-shape, yeah, T-shape types. And this the pictures, yeah. After we do the retraction, we can see there is a helping and reduce well. So I would like to give the pooling survey. What definitive treatment are you planning to do? Yeah, in this case, whether anterior first or posterior first. You have 15 seconds, yeah, to vote. Is it? Do we have the result? Okay. Mostly, this 50-50, yeah. The anterior, all of them is anterior first, but 50-50 between posterior plating and column, yeah. But don't forget this one. There is of posterior wall involvement. Although this T-type, but there is little bit variation. There is posterior wall involvement. Okay, sorry, ini is the not work, so I will do the another sharing, yeah. Okay. Okay. This is the diagnosis is the judeolaternal T-type with the postural wall fractures and central dislocation. So this, what kind of approach do you prefer? Illuminal, Bodevetova, or choice of the fixation?
Sorry, Prof.
So
2 more
yes.
minutes.
Yeah.
2
Okay.
more
This one
minutes.
is it will finish soon. So in this case we do the illuminal approach, and we do the using quadrilateral buttress plate or hook plates. Yeah, with using if the first case is we use the two recon plates, but in this case we use one because of we use the recon LCP. Recon LCP is 4.5 and recon plate is 3.5. So if you would like to use one, you use your recon LCP because it's quite wide and thick. And then we go back to the prone position for performing of postural column plating. Why? Because there is in the CT scan we can see in 3D we can see there is postural wall involvement, postural wall fractures. So the illuminal is most widely used for the intra-pelvic approach, and low complication rate in the injury of for vessel, nerve, and the type of fixation according to the study, anterior column plate with the quadrilateral surface screw is the giving increase. Have the highest total stiffness and decrease maximum displacement. How about the outcome in T-type? According to the study, the amount of other type is the worst outcome of the T-type fractures. But in Hamad study, they show the result excellent to good clinical outcome in 75% of cases. This is 2 years follow-up in this case, and the patient, this is the current condition. The most important thing for Indonesian, for the Muslim is the patient have to do the praying, atahiyat praying position, and also the squatting, because that's the differentiate between Indonesian and others. Usually the chatting with the squatting position. Take-home message: plan the approach based on the fracture pattern, since it will determine your visualization and reduction. It is possible to combine stopa with the illuminal, and for the quadrilateral surface fractures, intrapelvic plate giving better stability for the quadrilateral surface fragment. Postural wall component is negative predictors for good functional outcome in T-shaped fractures. Thank you for the attention.
Thank you, Professor Ismail, for the nice and very informative lectures. And we proceed for the next topic. Next presentation will be delivered by Professor Terachai. It's about complex case example 2. Your time is 15 minutes, Professor. Time and screens, it's yours. Please.
Can you see my screen?
Yeah, very clear.
Yeah, I'm not sure how complex. Sometimes it's look not complex, but it's complicated later. I show you maybe 2 or 3 cases. I go really slow, or somebody want to discuss. I think it should be possible. Yeah. Okay. This is a 46 years old with a car accident. Okay. What is the diagnosis? Is anybody want to answer, or Gibran or Professor Ismail or anybody? Can you share? I think it should be, yeah.
Giving chance for the participant, Prof. There is obligation for them to ask.
Yeah. Man, for the panelists, if you want to share, or it's more fun with the discussion. Okay, look at the CT. You see the fractures of the anterior and the posterior column and the obturator foramen here, is your pubic. Yeah, it's broke here, so it should be, yeah, from the CT scan. Yeah, this is the fracture in the obturator foramen, and this is the posterior column fractures, and this is the anterior column fractures. So you have anterior, you have posterior. Yeah, this is transverse fractures. But this transverse fracture is extend into the obturator foramen. That means now you have T-type fractures, right? So Gibran, you are the T man. Do you want to share how to reduce, how to fix which one first, front or back? Or okay, one or two approach. Anybody want to share? If you have this case.
Okay, so I think I would go in from the most displaced first. And I think if I'm not mistaken, in the X-ray I see that the SI joint is also widened, so the ilium is externally rotated, I think.
Just a little bit, not that much.
Okay.
Yeah, we talk mainly on the acetabulum. Okay.
Yeah. So yeah, I think I will try to get the anterior first.
Anterior first?
Yes.
Why? You said the one is displaced most, right?
Yeah, but looking at the posterior, I think it's more comminuted, if I'm not mistaken. So I'll try to find a less comminuted one.
Less comminuted. Yeah. And so this is like a controversy. Which one is depend on the surgeon's experience, and sometimes you have to plan one approach, and sometimes with one approach is failed to reduce another column because the T-type one column is folding. Yeah, you have to try to reduce from different from the another opposite side of the approach. Yeah, so in this case, because of the posterior column is displaced most, yeah, so I think I want to reduce from the back and try to reduce the front from the back if possible. If cannot, then we have to make an anterior approach later. Yeah, so in this case, posterior approach, as Gibran said, we have this chance pin in the ischium to derotate, yeah, the column, the posterior column, yeah, and use this Fallabov clamp to reduce and compress the posterior column. Yeah, you see the chance screws and the Fallabov. Yeah, and can fix, reduce and fix with this posterior column plating. Now you look at this X-ray. What happened? You see the posterior column here. It's still displaced. Yeah. So that means you have to try to reduce this posterior column by posterior. This anterior column here. Yeah, you have to reduce anterior column from the posterior approach. And this is the collinear reduction clamps. You go from the back and you use this hook, go to the front. Yeah, it's not easy to apply. Yeah, as I tell you, you have to clean the fractures and move the clamp close to the bone carefully to reduce the front from the back. Yeah, and now here the fracture is reduced. Yeah, you see the very nice collinear reduction clamps. And then we put the antegrade, posterior to anterior column screws. That means we reduce and fix from the back. Yeah, and this is another additional posterior wall and column plating. And this is the column, posterior to anterior column screw, or we call it antegrade Raymi screws. Yeah, so if we know the anatomy, we have the technique that we can reduce, So T-type is possible to reduce from the back. Is there any question for this case?
I think it's an opportunity for me to ask you, what do you think about the, a group of surgeons in Bern, Switzerland, I think they advocate using the surgical hip dislocation for these complex transverse type fractures. I would like to know what's your opinion on that.
Yeah. I think it's a good option. I think maybe now I just read last week that there is another publication that you use the surgical dislocation of the hip, dislocate the hip with the trochanteric flip, and then you can see all inside of the acetabulum, and you can reduce this directly. For me, I still don't have the experience with this surgical dislocation, but should be another option. Okay, I proceed.
Yes.
This is another case. You have this ilioischial line, iliopectineal disruption. So this is the transverse fractures, but is that some fracture non-displaced here? If you look at the CT scan, there is a non-displaced fracture here. So this is the T-type. And it's look not difficult one. Okay, Professor Ismail, which one
Yes,
you
Prof.
prefer? Front or back or whatever?
Yeah, this one is actually, could you go back to the X-ray, please?
Yes.
Yeah, okay. Oh yeah, anterior displacement. So I from the front, from the front, plating and screwing, posterior column screw.
Yes, very good option. Ribang, are you agree? Or you do different?
Yeah. I think I would agree, yes.
Yeah, I think it's just a simple anterior column, right? So we go and then we make a column screw. If we can reduce this from the anterior, we can reduce the posterior column from the anterior, not be difficult one, right? So I do as the same. I do the anterior approach and reduce the fractures. It's not that bad. Yeah. However, now when I try to reduce the posterior column from the front, I cannot reduce it. You can see here, it's not going back. I try many times, maybe half an hour, try to reduce, try to manipulate, but it cannot reduce. What next? I try to use the plate. I'm not sure. Maybe I use the plate and then I push the plate to reduce the fractures. However, if you look carefully again, the posterior column is not reduced. So, what happened? What can I do now? Or maybe I accept it, but you see the gap here. This is the gap on the almost medial to the dome. So I think it's not a good reduction. So if you look carefully from this CT, you see this spike of the bone and here. So it's locked the reduction. You have to reduce, pull it down, and then you rotate it. It will reduce. But from the front, you cannot reduce this from the back. From the front, you cannot reduce these fractures because of it's locked here. The bony spike is locked. So I have to remove the plate from the front, and I go to the back, open reduction with the posterior Cocker-Langenbeck and posterior plating. And now go through the same approach on the front, and then I can push the plate and I reduce here the medial, the posterior column. It's perfect reduction. Anterior column is going back. And this is the post-op. I need the anterior and posterior approach in this case. So if I see this again, next time, I will go on the posterior. That's maybe is can be reduced. The posterior and anterior column I can reduce from the back. I think it should be possible. Yeah, so this is my reason to learn.
So you use the three position, yeah? Anterior, posterior, anterior. Eh?
Yes.
So dry, yeah. It will be dry. Dry meals.
Did you do it in one setting? I mean, you.
No. I remove all the. I make just the iliosacral screws, and then I remove all the plate, and then another setting. I go to the posterior. And anterior approach in the flip-flop is okay because you have already reduced and fixed the anterior already. It's not difficult one. You have just opened the surgical wound. Yeah. Any how many minutes I have now?
4 more minutes, Professor.
One more?
4 more minutes.
Okay.
4 minutes.
4 minutes. So the last case. Yeah. Again, this is the T-type fractures. To make the story short, look at the CT scan. Right? Yeah, you have a very comminuted anterior. Yeah, and posterior here not so comminuted, but again, you have to ask yourself, can you reduce this bony spike that has only here from the front again? Yeah, this may be the case after I have the first case that I cannot reduce. So how can you reduce these fractures? Which one? From back or front?
Going from your previous experience, then go from the back.
Yeah, but the problem is the quadrilateral surface is combination, yeah.
Yeah.
So you cannot doing the screwing, yeah, from the back. So that's why you maybe double approach after posterior, two approach, and then plating, yeah, because screwing is not good, I think, this one.
Yes, agree. So anterior, posterior, yeah, we already discussed or refer, right? So we go on the posterior first. You see, it's not difficult one. Yeah, this is a posterior column fixation. Now you have the perfect posterior column fixation, right? Anterior still displaced. Yeah, and it's comminuted, as Ismail said. You cannot make the screws or reduction from here. It's difficult. So this is another approach. Anterior approach by the stopper and the lateral window. Yeah, and now you can push the plate down, and this is the anterior to posterior column screws again. Yeah. And you can see this is a really nice long screws going down. Yeah, here. So in this T-type, we need both anterior and posterior approach, but you have to plan, otherwise you will be in a very sweating situation. Okay, thank you very much.
Thank you.
Yeah. So look at the X-ray carefully. Sometimes this is easy to reduce. This is difficult. This is really, really difficult one. If you reduce from the front. Thank you very much.
Thank you, Prof. Terachai, for the nice complex case example. So we invite Dr. Harisuko, Professor Ismail, and Prof. Terachai to go to the discussion session. Okay, I will try to invite Dr. Jorianto Johorning to unmute and ask the question directly to the presenter. Please, Dr. Jorianto. Still mute? Okay, Dr. Jorianto.
Dr. Imamul. sorry. We have another participants who wants to ask questions live, but I think that he hasn't got the raise hand correctly. So we will invite Dr. Albert Lesmana.
Okay, never mind, Dr. Albert.
Albert Lesmana, can you?
Dr. Albert Lesmana,
can
please.
you unmute Dr. Albert Lesmana and turn on his video?
Okay. Yeah,
Okay,
please, Dr. Albert.
Good afternoon, Prof. Terachai and Prof. Ismail and Dr. Hari. Thank you for the opportunity. I would like to ask, sometimes in our setting, especially in the multiple trauma patient, we cannot perform the surgery in the window period that's within 5 to 10 days usually. How would you like to approach the patient in the lab setting, because we found it really difficult to reduce the fracture after 2 weeks? Would you, especially in 50 years old or 60 years old patient, would you like to perform or reduce first the fracture and then later convert it to arthroplasty, or will you wait until the fracture healed and then perform the arthroplasty right away? Thank you, sir.
Okay. Professor Terachai, please.
You mean the immediate arthroplasty, right?
Yeah, acute. Acute total hip. Yeah, acute.
Dr. Albert?
Yes, sir.
I think it's if you get the patient maybe 2 weeks, I think we still can make if you have to make a more dissection or release of the soft tissue or release of the ligament, like sarcotubulus ligament, sarcospinous ligament, you have to release, and you have to release the fractures. Like if you go from the front, you have to release all the quadrilateral surface by using the cup going down. Yeah, but it's not easy if you don't know the anatomy. You have the obturator artery, you have the nerve there, yeah, or you have to make a posterior approach and try to clean up the obturator internus muscle from the back. That means you will have to release the soft tissue. I think 3 weeks still possible, but more than 3 weeks, then it's not possible. It should be, you have to maybe sometime release one side and then go to another side and then release another side and reduce it, and then you go back again. So it's not that easy one. For the total hip, I think if there is 3 weeks more, yeah, I try to reduce it as possible, but more or less, if you have the fracture that is not reduced or medial displacement, even the total hip is not easy one. So it's the goal of you, what you need or what you aim. If the fracture is more than 3 weeks, yeah, maybe we try to construct the acetabulum, but not anatomical reduction. But if more than less than 2 weeks, then the goal is anatomical reduction of the acetabulum.
Okay. Professor Ismail?
Yes, okay. So I in my practice, in our practice, and also in the study, according to study, we will do the acute total hip arthroplasty. For the first is the geriatric fracture, so more than 65 years old, with the combination, yeah. I mean the associated types, mark displacement. For the mark displacement, combination, associated type, we do the acute total hip arthroplasty. Or number 2 is with the femoral head fractures. And because if there is femoral head fractures, the prognosis is very bad. And then there is dome combination. That's why we do the acute total hip arthroplasty. And for the 2 weeks, I think agree with Prof. Terajai, we should, especially in young adult, and we do the reduction, open reduction, release with the maximum exposures, release, and do the open reduction. Cannot by screwing or percutaneously, we cannot. So open up, sometime like in several cases, not only ileoinguinal but also combine it with the stop approach. Some in one cases, I using the ileoinguinal and add it with the pararectus approach, because in the ileoinguinal is open up, so we can extend vertically from the vessel side to vertically. We can make it big exposures to help the reduction. That's the especially for the elementary type. In elderly, also although in elderly, if the type is elementary, we also try as much as possible to do the open reduction. But if the cumulative associated type, dome comminution, femoral head fractures, we do the acute total hip arthroplasty.
Thank you, Prof. Ismail. Dr. Hari?
Yes. Okay. And my opinion is depend on the age of the patient, activity of the patient, and the pattern of the fracture for the acetabulum. If there is in the old patient more than 60 years old, we can do with the acute hip arthroplasty, because of all we do if the pattern is a complex fracture, will be the outcome, the long outcome is OA. So we choose a good hip arthroplasty. Thank you.
Okay. So next question is for Dr. Hari from Dr. Iputusan di Kumara. What if we try to put external fixator for your case? Is it possible although we don't have C-clamp? Because pelvic binder maybe cannot be used for a long time due to pressure, can cause pressure sore on the affected skin. Please, Dr. Hari.
Yes, thank you. Usually we always control for the skin traction, and we choose the soft band before we choose the elastic for band. If we use the skin traction, but usually we choose the skeletal traction because we need the loading bearing is more than 5 kilograms.
Okay, thank you, Dr. Hari. I think there is one more live question from Dr. Ido Prabowo. I invite Dr. Ido Prabowo to switch on the camera and unmute the microphone. Please, Dr. Ido.
Mr. Arman, can you find Dr. Ido and on camera? Put him on camera.
Okay, one more time, maybe. Dr. Ido Prabowo.
We don't have Dr. Ido Prabowo.
Okay.
So
Okay then. Okay, I think he's cut out from the Zoom.
Yeah, yeah.
So
Okay.
you may proceed. Thank you.
And how about Dr. Akbar? Dr. Akbar Mafaza, you raise hand. Please join us.
Right. Okay.
yes, he is available now.
Okay, never mind.
Okay. Okay. I think he's cut off.
Yeah, so I think I will ask the.
Oh, okay, okay.
have
He's
Dr.
on. He's
Akbar
on now.
Mafaza now.
He's on now. Okay.
Okay, Dr. Akbar Mafaza, please.
Yes, Doctor. Thank
Tell
you.
the question.
Good afternoon. Thanks for the good presentation and this opportunity. I have one question for Dr. Hari Suko.
Kompleks fracture ng pelvis eh.
Yes, in your experience, how could we manage the patient with unstable pelvic fracture who need pelvic binder, but also have associated greater trochanter fracture. The second question, in elderly patient, how long after the surgery you will advise to the patient to take the weight bearing? Thank you for the opportunity.
Is it clear for the question, Prof. Terachai?
No. What is the first
Okay.
question? I cannot hear
First
it.
question, you can repeat the first question, Dr. Akbar.
Yes, doctor. First question, in your experience, how could we manage the patient with unstable pelvic fracture who need pelvic binder, but also have associated greater trochanter fracture, doctor?
With the greater trochanter fracture, we can put the skeletal traction for the greater trochanter, and we
Dr. Hari first.
with the leg screw, the long leg screw, and we can traction from the trochanteric for the greater trochanteric, and we pelvic bandage. The second question until we take the photo and the clinical union.
Okay. I asked Dr. Akbar for the second question. What is the second question?
Yes, doctor. For the second question, in elderly patient, how long after the surgery you will advise to the patient to take the weight bearing?
Okay, I think it's clear.
Please,
Professor Terachai.
Yeah, if you fix if you fix it well, most of my case I just put the partial weight bearing, because I am sure that I have to fix the with the long anterior to posterior column screws. Most of the elderly case, it is the anterior column with posterior hemitransverse. Yeah, and when you approach it, you fix it, you have to make it very secure, because the elderly, you cannot tell them to make a toe touch. They always do whatever they want. Yeah, but in the young, I think because of the good bone qualities, yeah, I prefer to make a partial weight bearing 10 to 15 kilos. And for the first question, if you have the pelvic fracture with the subtroch or intertrochanteric, right, unstable pelvic fractures, yeah, my case, I use the X-fix pelvic external fixators, and then I join it down to the shaft of the femur to fix the intertrochanteric and the pelvic at the same time. So you have the chance pin in the femur shaft and the distal femur, yeah, and also the pelvic external fixators that join together.
Okay, thank you. Dr. Harisuko?
Yes.
Any addition for this question?
I've already answered for this question.
Okay.
Yes.
Yes. To Prof. Ismail.
Yes, and for elderly, yeah, for elderly, so mostly the acetabular is in the young adult. Right? So in the elderly, usually because of the osteoporotic and also the geriatrics, so they usually, if the complex associated types and femoral head or dome, yeah, three indication that I mentioned. So I do the acute total hip arthroplasty, and of course also combine it with the plating, yeah, platings for posterior column platings and massive bone graft and total hip. Why? Because I would like to do early weight bearing, full weight bearing directly after the surgery. Because in elderly usually we would like to prevent another complication like pneumonia, urinary tract infection, decubitus, etc., right? But if the simple type, there is some of the cases because of the geriatric acetabular fracture. If the patient have the simple elementary type, usually we usually put the screwing, with the screwing technique percutaneously, and of course in this case I will start it with the partial weight bearing. Yeah, no, not weight bearing. I mean partial weight bearing. If you did not confident with your fixation, I delay for the non-weight bearing. I mean with the wheelchair, but the patient but the patient can mobilize from the bed to the wheelchair.
Yeah.
Yeah, I think it's clear enough for the answer, Dr. Akbar. Okay, before we finish the session, I will ask each presenter please to give tips and tricks for especially for the young orthopedic surgeons to manage the pelvic acetabular fractures to become not be complicated. Okay, Professor Teracai, is there any message for us, the young orthopedics?
I think it's not the easy one. Yeah, the one that you can make by yourself. Yeah, for the young or the starters is the posterior wall and the posterior column. I think that's the possibility that you can do by yourself. But be careful when you have the posterior wall, posterior column, looking for the articular impaction, reduction the articular surface and bone grafting it from the greater to candors. And that is the point. More than that one, I think you need another training for the trauma fellowship or
yeah. Connection is
overlap. I think it's most important one.
Okay, thank you, Professor. Dr. Harisuko, is there any message for us?
Yes, as in the young orthopedic or in the rural hospital like me, we must be always remember we treat the patient as a whole, not only treat the pelvis, not only treat the photo. We must be comprehensive treatment for this patient, and we must be know the long time outcome for this patient. Maybe if we can do operatively, sometime any place to conservative treatment. Thank you.
Thank you, Dr. Hari. And finally, Professor Ismail.
Yes, thank you, Dr. Imamul. So like mentioned by Prof. Teracai, and also in our previous slide on first session, the most important thing is anatomy. You have to do, if you know well, the anatomy of the anterior column, posterior column, and you can classify. So if you cannot classify, maybe you cannot understand the fracture pattern and do not do the surgery after leave it. Yeah, for the simple one, maybe the posterior wall is the most simple and also the most often. Yeah, actually among the acetabular fractures, the posterior wall is the most often acetabular fractures. And if you like to do it after the training, if you have opportunity, facilitate your operating theaters, please equip with the equipment. Yeah, the like forceps, collinear clamp, the both spike pusher, and etc. There is at least five instruments that you have equipped your operating theaters for the acetabular surgery. And of course, with using the fluorescent table and then C-arm, after you have that good instrument, it will help you. And this last but not least, especially for Indonesian, in Indonesia setting, actually, if you have the policy, if you get access for the policymakers, you order the instrument and implant set, pelvic acetabular instrument that also equipped with the screwing, because actually the screw and plate is very special. It will help you because the screw usually they have a long screw, because most of our storage is the screw is the maximum is maybe for if 3.5 is 60, right? Yeah. In acetabular and pelvic usually for the column screw 120, at least 120, 100 that they don't have. So if there is, so you have to gradually increase the
competent and also the facilitate with the adapted with the new technique in the acetabular surgery. So that's why you have to do the fellowship, to do the fellowship and train in pelvic acetabular surgery. Thank you.
Yeah, thank you
I
very
think
much.
another one is set up the team.
Yeah.
Set up the team and work together in the closer area, like in maybe 100 kilometers around. You should form a team, and then you may share the instrument together, and learning together. If you do one-man show, it's not easy one for the acetabular fractures. If you have two, it's faster, and it can be very helpful from each others to help to reduce and maintain the fractures. Yeah.
Okay. Thank you very much for the presenter. This is the final session of this afternoon session. And I would like to thanks to all of the speakers, Dr. Radi, Professor Ismail, Professor Terachai, Dr. Datu Abdul Rauf, Dr. Gibran, and last not least, Dr. Harisuko for fulfill this session. And hopefully we can still continue learning, and this session is very fruitful lecture, fruitful lesson from the distinguished lecturer. Okay, last I will return back to the Master of Ceremony, Dr. Jepta. Please, Dr. Jepta.
Thank you, Dr.
Thank you very
Imam
much.
Aziz Albar, for moderating this afternoon's event. It has truly been a remarkable event. And I would like to remind all speakers to not storm off yet, because we want to document your present. So if I may ask for all the speakers to prepare first to turn on the camera, while the host will show us the next session of the AOA webinar, which is going to be in 2 months. And it is going to be hosted by our Orthopedic Society over in Brunei Darussalam. So it's going to be on Saturday, the 20th of November, 2021 on 6 p.m. Singapore time. So please mark that and put that in your calendar. And we're going to be talking about musculoskeletal infection, one of the topics that is quite common in the Southeast Asian countries. And then we move over now for all the speakers to have the camera on. And then I will count down from 3 to 1. We have 2 pages. So please put the biggest smile, see towards the camera. And then first page, 3, 2, 1. And then for the second screenshot, second page, 3, 2, 1. And that's it for the photo session. So I would like to thank again to all speakers. It's been, there has been priceless lessons, and thank you for all participants who have been very eager and active in asking questions. So I think that concludes our afternoon. So again, lastly, I would like to wish you all safe in this pandemic, and hopefully somewhere in the near future, we can have, instead of AOA webinar, we can have a physical seminar somewhere in the Southeast Asian country. Thank you very much. This is Jeff Tobing signing out. Bye-bye.
Thank you very much. Bye.
Thank you, Prof.
Bye. Thank you.
Terima kasih semuanya.
Terima kasih Dr. Yudis, Mas
Juga.
Arman, boleh di close.
Terima kasih.
Terima kasih semuanya dok. Alhamdulillah beres-beres.
Mantap. Thank you
Alhamdulillah
ya Mbak.
beres. Ya dok,
Mas
terima
semua.
kasih.
Ini
Ya,
udah,
Mas juga
udah.
dok. Semua thank you.
VJ
Sehat-sehat semua.
Daniel nggak ada apa-apanya.
Thank you.
VJ Daniel
Plong ya,
who?
plong.
VJ Daniel who?
Ini tadi kurang tadi nggak nyalain kamera.
Patut ditanya.
Dr. Gibran doang yang tanya jadi.
Ini masih ada viewersnya. Sorry.
Untung sholat dulu, pas sholat balik, ditanya nih.
Apa-apa Mas Yuda, biar ini viewernya lihat.
Dr. Yuda
Tadi
mau
bentar
di
lagi
stop
nih,
live YouTube-nya
Dr.
dok.
Depta direkrut nih, MC profesional dia.
Jadi ini kayaknya barusan
Ya, Dok.
ada nggak ganti-ganti kayaknya setelah ini ya.
Luar biasa. Udah pokoknya Dr. Jeff.
Mantap.
Kalau MC
MC
pokoknya.
abadi.
Makasih ya dok.
Terima kasih semuanya.
Terima kasih semuanya.
Izin live ya.
Ya.